Welcome, everyone. We're going to go ahead and get started with our evening program. I'm Roxana Ballinger. I work at Health and Human Services here, and I also co-chair the Saving Lives Task Force with Commissioner Wally Overman, and I said this during our lunchtime event, so I have to repeat it. This summer, the task force will be celebrating its 10th year anniversary. Time has just gone by so quickly. But what I want to say is the success of the task force really is attributed to Wally Overman there, our Board of Commissioner. He's the one who's really started it, and he's really provided a lot of great leadership for it. So thank you, Wally. I'm going to turn it over to Claire Mills now with AHEC, so she can talk a little bit about credits and CMEs and all that.
Well, hello. I'm Claire Mills with Eastern AHEC. Up for about 5 minutes or so there, we're scrolling through all about the credits. If we are offering CME tonight, contact hours, pharmacy credit. If you are a pharmacist and did not register, that's okay. We can get you in. I just want to make sure we have your numbers so that we can file for that credit for you. I have to think of anything else. Pharmacy, CME, PAs, anyway, and if there are nurse practitioners here, you will get contact hours, but it will say that it's been approved for CME on there so that you won't have an issue with that. If you have any questions, feel free to reach out to me or to Catherine. Raise your hand, Catherine. Even after tonight, you can always get up with us, or you can get up with anybody at Eastern AHEC, and they'll direct you our way. We are pleased to be a part of this and support the great work that's being done down in Dare County.
Okay, thank you, Claire. Next, I want to introduce Wally Overman, Dare County Board of Commissioner and co-chair of the Saving Lives Task Force for opening remarks.
Welcome, everyone. I'm Wally Overman, Vice Chairman of Dare County Board of Commissioners for just a little while longer, but the main thing is I co-chair the Saving Lives Task Force with Roxana Ballinger, and it has been a pleasure working with Roxana for the last 10 years. And as I always say, she is the best co-chair and hardest working co-chair in the state of North Carolina. So Roxana, thank you for all you've done. I want to welcome everyone here this evening. Thank you so much for being here. You're going to experience an exciting and enlightening presentation today from Dr. Stephen Loyd, who will be introduced to you momentarily. We appreciate his being here, and I know we will all benefit tremendously from his presentation. Again, thanks for being here today and making the effort to come out on this beautiful evening for what you're going to find out to be an absolutely wonderful presentation. Thank you.
Next, I'd like to introduce Dr. Sanchez. Dr. Sanchez is a family medicine and urgent care physician with Outer Banks Health. He's also the medical director of Changing Tides, a drug and alcohol treatment center here locally in Kitty Hawk. And Dr. Sanchez.
Okay, thank you. I'd like to go ahead and introduce our guest speaker for tonight. I was here at the afternoon session as well, and I was able to meet Dr. Loyd before the session in the little boys' room. But I can attest to you that he's a great guy, a great speaker as well, and sure to impress. Formally, Dr. Stephen Loyd is an internal medicine and addiction medicine physician who graduated medical school and residency from the James Killen College of Medicine at East Tennessee State University. He currently serves as the Vice President of the Tennessee Board of Medical Examiners. Dr. Loyd was the Assistant Commissioner, or opioid czar, for the Substance Abuse Services in the Tennessee Department of Mental Health and Substance Abuse Services under Governor Bill Haslam's administration. He served as an expert witness. He has served as an expert witness in more than 20 federal and state cases against physicians who are improperly prescribing controlled substances. Dr. Loyd was named an advocate for action by the Office of National Drug Control Policy, which is an office of the President of the United States. He has delivered over 500 educational lectures on addiction and treatment of opioid use disorder and the proper prescribing of controlled substances. Dr. Loyd was an original and still active member of the Treatment of Chronic Pain Guidelines Committee, which defined pain treatment for providers in the state of Tennessee. He has worked as an addiction specialist or addiction medicine physician in both the inpatient and outpatient settings, specializing in the treatment of opioid-dependent pregnant women. Dr. Loyd has served on multiple drug courts in Tennessee and remains an active participant in drug court in the 4th Judicial District under Judge Dwayne Sloan. He has worked with multiple community-level anti-drug coalitions from Johnson to Shelby County, and has worked with all levels of state law enforcement, mainly the Tennessee Bureau of Investigation. He currently serves as Chief Medical Officer for Cedar Recovery in Tennessee and is the current chair of the Tennessee Opioid Abatement Council, appointed by the current Tennessee Governor Bill Lee. Dr. Loyd himself has been in recovery from both opioid and benzodiazepine addiction for almost 20 years now, since July 8th of 2004. And with that, I hope you'll join me in welcoming our guest speaker for this evening's presentation, Dr. Stephen Loyd.
I'm not the only one charging my phone over here, so and I lost the clicker earlier today, so I'll lose it again. Hey, thank you all for coming out. Every time I come to things, I always am glad when people show up. It's better than the alternative. I want to try to get a feel. I know I have one radiologist in the room. I know that for sure. Okay, here we go. So I'm sorry. You'll see it. You'll just see pictures of it. So I think North Carolina probably has some prescribing guidelines, CME you got to do, and so I've tried to get the radiologist and pathologist out of that forever, but I'll try to make it at least a little bit worth your while. Do you have kids? Okay, well, I can't even help you there, all right? I was going to say, at least I can teach you why they're stupid, which I'm going to do here in a little while. All right, so do we have, what kind of mix of providers? Do we have nurse practitioners? Okay, a bunch, psychiatric or primary care? Oh, okay, internal, okay. And then docs? Okay, and what specialty? I know we got radiology. What do you do? Family medicine, okay. And the others, Dr. Sanchez? And right here? Pediatrics, okay. Okay, so you work in the hospital? Okay, well, you're going to see what I'm talking about. Okay, I was just trying to get a feel for it. Pharmacist, do I have pharmacists here? Okay. Are we segregated out here? All right. So I'll try to have something for everybody. I'll tell you this, that I am an internal medicine physician by training. I've ran residency programs, and I worked in the VA system for about 10 years. I worked in academics for 15 years. And I practice addiction medicine now for the last 15 years. If you told me I had to go back in the hospital now and work as a hospitalist, I'm sorry, I would quit. I didn't mind the work back then, but I love what I do now. And the truth is I didn't know anything at all about addiction when I was coming through medical school or residency. And you all know, you know what we're taught. I told the group this morning, the only provider we had was Dr. Sanchez. There was no other providers in the room. And you know what we learn in our training around addiction and proper prescribing and controlled substances. We don't learn anything at all. Zero. And I'm always amazed by that because addiction is actually the #1 health problem in the United States. And if you don't believe me, just look at how many people die of nicotine addiction. All right, it's the #1 preventable cause of death in the world. Yet somehow we don't get training on it in medical school, residency, PA school, or nursing school. And so working really hard to get that changed. Medical schools and nursing schools, PA schools keep coming up and saying we don't have room for it in our curriculum. It's the #1 health problem in the United States. You don't have room for the #1 thing. And I can tell you all this. I'm probably not going to tell you things that you don't already know, but you do a lot of workups on people for stuff that is a waste of money because it turns out it's addiction. And I do it all the time. Right? I don't know how many $10 million GI workups I've canceled when I went in and figured out my patient had alcohol use disorder because nobody asked. And we don't feel comfortable and we don't know what we're looking for. And then we start talking about prescribing controlled substances. And guys, this pendulum swung too far on this. I'm not going to come in here and say we need to get rid of opioids. We absolutely don't. That would be heresy. They help a lot of people, all right? And there's no question about that. But when the pendulum swung on this, it swung too far. We began to get scared of practicing medicine. You had councils like I sit on trying to define what pain management is. Boy, that's pretty tough, right? And so hopefully we'll see the pendulum swing back here a little bit. But I can tell you that the cases that I've worked, these are doctors and nurse practitioners. I only had one PA that I've worked against. These are people, these are criminals, guys. These aren't people that wrote one or two too many Lortab or Percocet. These are absolute criminals running pill mills, holding prescriptions over young women's heads for sex. I mean, the things that I've seen just blows my brain. So when you hear me say that I work cases, these are people that need to be in prison. These aren't somebody that just had bad documentation for writing opioid or benzodiazepines. And so what I hope to do here tonight is a few things. I want to give you just a brief framework of addiction. What is it? Because the truth is that even though you all practice medicine and have been for a long time, you'd be hard-pressed to define it. And I think you'd be hard-pressed to define what the risk factors are for it. And I understand that. I mean, how would you know? And so I'm going to try to teach you that because I want to give you something you can use in the office with your patients. Because when you're getting ready to write a prescription for a pain medication, how can you have some kind of feeling that you're not getting ready to set this patient on a path that's going to destroy their life over the next 10 years? And that's not all on us, right? But there's some things we can do due diligence-wise to try to shake those out, and I'm going to try to help you with that. And because the truth is, I understood none of this. And so when I got out of treatment back in 2004, and I'll talk about that a little bit as we get through, I went and took a prescribing course at Vanderbilt. They said, you need to take a prescribing course. And I wasn't an over-prescriber, but I didn't know anything at all about prescribing. When I went to the course, I was the only person in there not sent by their state medical board. And the course was unbelievably awesome. I was sitting there the whole time. It was 3 days. It was phenomenal. I said, this ought to be taught in every residency program in the United States. This needs to be it. It still is not. Do you know when we teach people about prescribing? We actually do. Do you know when we teach them? When they get in trouble with their medical boards. We teach them after the fact. As backwards as that is exactly what we do. And so what we're trying to do is get these prescribing courses into medical schools, into residency schools. Nurse practitioners, we throw nurse practitioners out there to die. They go in, they get a job with a doc. Okay, the doc writes the recipe, the nurse practitioner comes along and follows the recipe and doesn't understand, and the doc didn't understand either, by the way, and the doc is supposed to be supervising them. We absolutely throw our nurse practitioners and PAs to the wolves, and we've got to stop doing that. I had a case where we had a nurse practitioner that lost her license over this, and she had only been out of nurse practitioner school for 6 months when the clinic she was working at got raided. She was a single mom. She worked her way through NP school as an ICU nurse. I mean, that's the one you want. And she got caught up in the wrong thing, and the feds went after her. And I tried my best. I said, we can defend you, we can defend you. And she wouldn't do it because she was looking at 50 years. Because when you get caught in a prescribing case and you're working in the practice, they use something called RICO laws. I don't know if y'all know what those are. I didn't know what they were. Your sentencing goes on the number of pills prescribed, okay? And they don't only count the ones you prescribe, they count the one all your partners prescribe. And then they stack them on all of you, all the way around. And so she was looking at 50 years, and she said, I can't risk that. She had 2 young kids. And so we've got to do a better job with that. So hopefully I'll be able to do that. I want to talk to you about systems of care. And we have a few young docs in the room. So you guys came through whenever we did competency training through the ACGME. And one of the competencies is systems-based practice. And I used to run residency programs, and to be honest with you, we pencil whipped that competency. Nobody knew what it was. And guys, systems-based practice is probably the most important competencies that we learn in our training. And it's not consult social work. That's not what I'm talking about. You have to understand the system of care that your patient is stepping into, because you're going to have multiple people out here in the world that are making decisions on your patient that have no medical training. They don't have a license, okay? And I can just tell you, jailers, maybe a high school education, deciding which medications to start and stop on patients. If this was diabetes, it was hypertension, there'd be riots in the street. But it's addiction, so nobody cares, because it's looked at as a moral failure, and they brought it on themselves. So I want you to understand the system of care. I'm going to use a couple of stories there around that. And I was trying to think one other objective they wanted me to cover. Let me see what it is. Make sure I got it. We're going to look at some emerging drugs. Anybody in the room ever heard of xylazine? Okay, so xylazine's one that I hadn't seen before. And I live in Tennessee. Northeast Tennessee is where I grew up. I live in Nashville now. And if it's a drug, we'll do it. Tennessee, Western North Carolina. I grew up about 45 miles from Asheville, North Carolina. So that's where I'm from. And the whole, that whole end down there, Western North Carolina, East Tennessee, Eastern Kentucky, Southwest Virginia, and then Southern West Virginia. All right, if you talk about the opioid crisis and you don't mention that circle that I just drew, you don't know what you're talking about. And emerging drugs are always going to show up there. The latest one is xylazine. I had no clue what it was. Well, it's an animal tranquilizer, so I shouldn't have any clue what it was. But I kept seeing my patients, and I knew they were impaired, but their drug screens were negative, okay? And we probably need to talk about drug screens. I don't have any slides on it, but we need to understand what the limitations of drug screens are. So I knew my patient was impaired. The drug screen looks normal, so where do I learn? Call law enforcement. Law enforcement will tell you. Okay, North Carolina has a Bureau of Investigation, guarantee it, just like we do in Tennessee. So that's where I learned about xylazine. And with xylazine, what you're going to see, it's going to be adulterated in just about everything, and you're going to see horrible necrosis at injection sites. The first one I ever saw, the kid lost his arm, and it was by far the worst gangrene I'd ever seen. And I worked in the VA system for 15 years. And it was just unbelievable what xylazine will do to your skin. It is just amazing. I don't have any pictures of it. We'll talk about emerging trends a little bit. And then the last thing is that fentanyl is absolutely in everything, okay? It is in everything. And when I say everything, I mean stimulants. It's in marijuana. It is in marijuana as well. Marijuana, it is in cocaine. It is in methamphetamine. Matter of fact, it's one of the fastest rising groups of overdose deaths we have in the United States right now, and these people aren't using opioids. They're using these other drugs, and they've been using them chronically for a long time, going about their lives. Guys, there's a lot of chronic drug users in the world, and they have jobs, okay, and they have families. And now fentanyl is getting adulterated in their supply and killing them. So we need to be aware of that because it's a little bit different approach. So, let's see. Well, somebody help me. I get squirrely with that. So I want to give a disclaimer about my slides. These are kind of my slides. I sent them slides, but they have these copyright rules that they have to follow, and I don't follow any of those copyright rules. And I would put the NFL logo up there if I could. So I don't follow those. So some of the pictures will throw me off a little bit because they're not the ones I have. But I want to start off with talking about a turtle on a fence post, and I'm going to and kind of build around this a little bit. So one of the things that we didn't talk about in my introduction is something that you need to know because it's important. It's how I want to lead into this. Anybody see the Hulu series Dopesick? All right, so you saw it, a few people. The rest of you, shame on you. Go watch it. Dopesick is the story of the Sackler family and the promotion of the drug OxyContin, which kind of led us where we are today. And in that series, there is a doctor who gets addicted to the drugs that he's prescribing. It's played by Michael Keaton, and that's me. So that is actually my story. From episode 3 on, everything you see in Dopesick actually happened in my life. And so my friend Beth Macy wrote the book. She's from Southwest Virginia. She's from Roanoke. And she wrote the book, The Opioid Crisis in Southwest Virginia. And near the end of the book, she had asked around, says, is there any hope out there? And so she said that 4 different people gave her my name. And so she called me up, and Beth and I got to be friends through that. Her book sold about 500,000 copies, which put it as a New York Times bestseller. She called me about 2 years into it, and she said, hey, Steve, she said, they want to make my book into a Hulu series. I said, oh, that's great, Beth. That's wonderful. What's Hulu? I had no clue what Hulu was. And then she followed up with, it's a streaming service. Like, that's going to help me. So she says, like Netflix. And I said, oh, that's great. And she says, we're going to rotate it around a fictional doctor, and we want the fictional doctor to have his own addiction. Would you help us with that? And I said, sure. I've never written anything in my life. And she said, you don't really have to. You can just tell us if this scenario fits what would happen in medicine. And I said, sure. So it was during the pandemic. The writers were in California. Beth was in Roanoke, and I was in Nashville. And every scenario they came up with was something that wouldn't be how we did it in the hospital, right? There would be something here, something there would have prevented that from happening. And finally, our producer, a young guy named Danny Strong, Danny said, well, Steve, why don't we just use your stories? We know they happened. The first thing that popped through my mind was, well, I plan on taking those to my grave. So that was one reason we weren't going to use them. And really, I thought about it for 5 seconds, and here's what I came up with. What if you had a disease you never saw anybody get better from? All right, what if you had that? For me, I always think about pancreatic cancer, right? It's a death sentence. You're going to die in 6 months, right? Almost 100 times out of 100. You know, what's it like knowing you have that disease and you never saw anybody get better from it? And a lot of times that's addiction, right? And I thought about it literally for 10 seconds, and I said yes. And so I just started telling them stories. So everything that happens from episode 3 on in Dopesick actually happened in my life. Those are all true stories. The only Hollywood there is I didn't relapse. and we made the Keaton character relapse. And it was really a statement by me because I wanted to put him on Suboxone because I knew his physician's health program wouldn't let him have a license, and I wanted people to know that because I think that's wrong. And then the other thing is I didn't buy a school bus. He buys a school bus to take people to treatment, and I probably should have. So when you see somebody in recovery, I want you to think about this picture I have up here. I'm a Tennessean. I take Tennessee with me wherever I go. The author Alex Haley is a Tennessean. He wrote the book Roots in the early 1970s and made it into a miniseries on TV. Alex's family was enslaved in West Tennessee. He grew up around Knoxville and Norris, Tennessee. And he talks about a turtle on a fence post. And unfortunately, it's not mine, but I love the analogy. What's the one thing you see when you see that poor turtle up there on that fence post? You know one thing for certain. What is it? It didn't get there by itself, right? It did not shimmy up that fence post. When you see somebody in recovery, you see me standing in front of you today, I'm a turtle on a fence post. I am here because somebody put me here. I stepped into a system of care that has a 95% success rate. Doctors that struggle with substance use disorder, 95% success rate at 5 years, right? We don't bat that with strep throat, okay? But we bat it with substance use disorder. What's the success rate of somebody walking in off the street into an AA meeting and being in recovery in 5 years? Anybody know? It's less than 10%. It's less than 10%. And it has nothing to do with the smartness or anything of the patient itself. It has everything to do with the system of care that they step into. So there's two systems of care in the United States right now. There's a system of care for substance use disorder if you have resources. You're a doctor, you're a lawyer, you're a judge, you're a professional athlete. You get access to this, and then everybody else gets this, okay? And guys, these two things are markedly different, markedly different. It's not even comparing apples to apples. And I am no longer willing to sit around and let that slide because it is absolutely not right. Because there is world-class treatment out there. I'm going to teach you here in a second. Addiction is about genetics, trauma, and opportunity. All right, that's the three things in addiction. And the big one driver is trauma. All right, there's world-class trauma help out there, guys, for physical, sexual, and emotional abuse. And it's ungodly expensive, and it's cash only, and my girls will never get it. Okay, they'll never get it. And so we wind up throwing medication at it, which is not a bad thing. I'm a believer in naltrexone, methadone, and buprenorphine. Why? Because it saves lives. Okay, I don't care what you think about it. And I don't care if you think it's trading one drug for another. You want to tell me you're just switching this for that. All that's wrong. It has a 75% mortality benefit. Name me another drug besides insulin that has a 75% mortality benefit. I'll save you some time. You can't. Okay, we have to learn how to utilize those drugs in a way that help our patients. So as I go through this, I want you to think about a turtle on a fence post. All right. So 107,622, what's that number? It's the number of overdose deaths in the United States in 2020, okay? Now, we've got more recent numbers, but I leave this one up here for a reason because I'm going to introduce you to one of those 107,622 here shortly. That number is so big now, it doesn't matter how big it gets, it's huge. So that is equivalent to a 747 airplane, fully loaded, crashing and burning every 36 hours around the clock for a year. That's that number. Yet you don't see newspaper articles on it, all right? It's not on the front page of the New York Times. Why? Because they happen in isolation and because the stigma is associated with addictive disease. There are people sitting in this room right now. There's somebody in here, always is, sitting at one of these tables right now, and you've got friends sitting at that table. And you've got somebody in your family struggling with this, and your friend sitting at the table don't know it, and neither does your Sunday school class because you're sitting there in silence. Why? Because you don't want anybody to know, because you're ashamed of it, or you don't know what to do about it, or you're embarrassed. And guys, as long as we keep doing that, we'll keep losing kids at the rate we're losing them, okay? And it's one of the reasons I decided not to live in the closet. I didn't live in the closet 1 second. When I got help with my addiction, I absolutely did not. I never denied it. I came back. I owned it from day one because I wanted people to see that you could get better, okay? And whenever we're doing this and we're over here and we don't tell anybody, we keep it to ourselves. The kid dies and they put in the newspaper, died of natural causes. How in the hell does a 24-year-old die of natural causes? Right? Almost always it's substance use disorder. I've got these warrior moms in Nashville. Nashville's a great recovery city. And these moms, when their kids died, they wrote it in their obituaries. My daughter lost her battle with heroin use disorder, and I'm still proud of her and I love her, right? These women are unbelievable, and I think that the mommies will wind up changing how things are looked at around this. So if you look at that quote I have up there, and y'all love this, I only have 2 slides that have words on them, and I only have about 10 slides total, maybe 12. But every system is designed perfectly to get the results that it gets, and that's actually true. So I'm not here to knock the current treatment system. There are people out there doing good work. But Einstein says you can't get out of a problem the same way you got in it, okay? So I think that we have to start to look at some new ways to attack this disease so that we can keep these kids alive and put them on a path to recovery. So every system is designed perfectly to get the results that it gets. 107-622 is our number, and there's no arguing that. That's just where we are right now. All right, so this is a terrible picture of a slot machine. My slot machine's a lot better. So I use a slot machine to teach addiction. We learned about addiction, to those of us that learned about it at all in medical school, as the biopsychosocial model, right? That's what we learned. And that sounds like psychobabble to me, so I use a slot machine. I get a slot machine a lot easier than that. Okay, what happens in the slot machine? The 3 7s come down on the pay line. That's when the money comes out the bottom. All right? And so I do this to risk stratify my patients, and you're in the front and center, and you're a female, so it's you. What's your name? All right, Suzanne comes to me. Suzanne's 25 years old, okay? And she's broken her leg. She's broken her femur. Everybody in here knows she's going to need pain medication for that, right? You don't send somebody home with a broken femur. Surgeon's going to operate on her, stick a rod in it. Physical therapists are going to be sadistic and mean as hell to her and hurt her, all right? So we're going to give her some pain medication, okay? So how do I know when I write this pain medication that I'm not saying, Suzanne, right? I'll get it. That I don't set Suzanne off on a 10-year journey to the heroin needle, losing her family, losing her kids, the whole deal. How do I know that? So states decided, okay, we're going to teach doctors, nurse practitioners, and PAs how to write medication. That's one of the committees I'm on. And so what we did, we got it all together, and in 55 typewritten single-space pages, we teach you how to do that. Okay? We do. Okay, nobody's ever read it, but we do. How long am I going to spend in the room with Suzanne? Maybe 7 minutes, if I'm lucky. Right, because I got to document, so that's going to be at least 5. I got about 15-minute blocked, right? I'm going to talk to somebody on my way in the door. I'm going to have about 7 minutes with her. How in the world can I get what I need in that 7 minutes? I use the slot machine. So the first 7 is the bio part of the biopsychosocial model, okay? It's just biology. 60% of addiction is genetic, okay? So how do I get to that? I could ask her about her own substance use. Probably not going to tell me, right? People are ashamed of that. All right, what's the most y'all ever had? What's the most anybody's ever admitted to drinking? Come on, tell me. You all know. 2. I've never had anybody drink more than 2, and I've been doing this for 25 years. Never had anybody drink more than 2. I told the crowd earlier today, this morning, that I had a guy in the VA one night, had a blood alcohol of 374, and he didn't admit to drinking any. So people don't want to talk about that. What will they talk about? Family history, okay? So tell me, when you were growing up, your mom and dad, did anybody have any substance use in your family? Well, Dr. Loyd, my daddy was a drinker, right? He would come home sometimes, he had drank his paycheck, he and mom would get in fights. They later got divorced, okay, over his drinking. So that's the definition of addiction. I'm going to talk about that in a second because that's continued use despite consequences. So now I'm sitting here, and the first 7 is on the pay line, all right? Family history, she has the biology. Second 7 is the psycho part of the biopsychosocial model. This one's easy, all right? What kind of household did you grow up in? None of us came out of normal households. Nobody in this room, they don't exist, okay? But some of us came out of places worse than others. Physical, sexual, emotional abuse, big T traumas, okay? Adverse childhood experiences. I had no clue what this was in medical school or residency. I think it's the second most important study ever done in the history of medicine, only behind hand washing in its impact. That's how big I think it is. So tell me, when you were growing up as a little girl and mom and dad, had those issues around his drinking, did it ever get physical? Okay. Yeah, Steve, sometimes dad would come home, mom would get on him, and he would hit her. Did you see that? Yes, that's emotional abuse. Okay, right off the bat. Now, if I want to dig a little deeper, mom gets divorced, has multiple guys come back in and out of the house through the years. No, it's what it is. It's the story I hear all the time. I am not an expert on sexual trauma. I am not, but I know how to identify it. And there's a way I can go about identifying it, even at the first office visit. So looking back now, were there things that happened as you were growing up that you realized weren't what they should have been, weren't right? Right? That's not a threatening question. And most of the time, you're going to get an honest answer over that. We find that out. So now I have a patient whose first 7 is on the pay line with biology, second 7 is on the pay line with emotional and sexual abuse, and all we're waiting on is the third 7. The third 7 is the social component of the biopsychosocial model. And it simply means what's widely available and socially acceptable. What's the most widely available, socially acceptable thing people have trouble with? That's easy, right? We can go downstairs and get it right now. Alcohol. Alcohol. If you're 21 years old, you got money, you can buy alcohol. How in the world did prescription pain medication become widely available and socially acceptable? Because we've known it's been addictive since the time of Hippocrates. We have. In the late 1980s, early 1990s, pain societies started to pop up around the United States, said, hey, we're undertreating chronic pain, right? These people are suffering unnecessarily because the opioids aren't as bad as we thought they were. They're not as dangerous as we thought they were. Of course, all this is propped up by Big Pharma. Big Pharma says if you take a long-acting medication, you got a less chance of being addicted to it because you don't have the peaks you do with the short-acting medication. Therefore, your risk of addiction is less. By the way, there is absolutely nothing that backs that up. Zero. And the FDA wound up putting it in the package insert for this new long-acting agent that's going to treat this disease that's just been created, and that drug was OxyContin. And you have to remember that the Sacklers are all doctors, have been for a long time. Matter of fact, they've used the same playbook here before because Daddy Sackler is the one that promoted Mommy's Little Helper, which you all know as diazepam or Valium. So they've done this before. So you go out, and we all know this, when we've got multiple drugs that we can pick to treat a disease, how do we decide which one? Y'all know it's the four things, right? First one, is it safe? Not does it work, is it safe? 2, does it work? Is it efficacious? 3, compliance, 1 time a day versus 5 times a day. And last is cost, right? That's the algorithm we run it through. So if you've got a new drug out there and you've got to overcome and try to change a doctor's prescribing habits, what's the first thing you got to overcome? Safety. And that's exactly what the Sacklers knew, and that's exactly what they did. And they said studies in the New England Journal of Medicine show that this medication has less than a 1% chance of addiction. How many doctors you think looked those studies up? Nobody. And it turns out it's not a study. It's called the Porter and Jick letter, and I actually have a slide of it. And it's a letter to the editor in a 1980 issue of the New England Journal of Medicine. Purdue Pharma started using that study, which is not a study, it's a letter to the editor, in 1993, 13 years after Dr. Jick sent it in to the New England Journal. As a matter of fact, when he was told that they were using it, he had no clue. And the only reason that he found out is he did a literature search and saw how many times it was cited in other people's literature and realized that's how they were doing it. So now, you got the 3 7s on the pay line. I got her sitting right in front of me. She's got a history she's got a family history of substance use disorder. She has a history of trauma, and now I'm getting ready to write this medication. Am I still going to write the opioid pain medication? Damn right I am. Why? Because she has a broken femur. That's why I'm going to write it, okay? But I need to talk to her. You're at risk, right? You got 2 risk factors. So the same thing as having diabetes and hypertension, right, for heart disease, same thing. And so there's 2 things here that worry me a little bit, okay? Some people will have trouble with medications like I'm going to write you. And so the first thing we're going to do is I'm going to write it for 4 days. Why am I going to write it for 4 days? Okay, starting out. You have to understand the difference between dependence and addiction, guys. Those are 2 different things, okay? Dependence means when I stop taking it, I get sick. That's it. I can do it to anybody in the room, okay? Addiction is the continued use despite consequences. Okay, I don't use the Audit C and all those tools because they take too long. What I look for in my history is, do I have continued use despite consequences? If I do, I'm going to bat about 800 with my diagnosis of addiction. Okay, I worked at a place several years ago and still do some work for them. We evaluate doctors, lawyers, judges, professional athletes, people in the entertainment industry. When they come to see me, they know what they're there for. Right? I am not a secret. Okay, and it's a 3-day evaluation, and it's $5,000 cash. Okay, so not an insignificant amount of money. So several years ago, I had this lawyer came in, and he sits down, and you got to remember, when they sit down with me, they want to start convincing me that this is a mistake. And I listen, I don't get mad, I get it. So I'm not, Dr. Loyd, I'm not sure why I'm here. And I said, well, I'm not either. All right, I only drink beer, I don't drink wine or liquor. I only drink wine, I don't drink beer or liquor. I never drink before 5 o'clock. I don't mix drinks. All right, and they tell me all this stuff. And so he tells me all this stuff, and I didn't even introduce myself yet. And he leans back and he crosses his leg like that, like you're sitting. His leg was up, and his pant cuff slid about halfway up his calf. He had an ankle monitor on. Well, I looked at that and I said, "Hey, what's with the jewelry?" And he said, "Well, I got a DUI." I said, "Okay." I said, "Was it your first one?" He said, "No, it was my 6th one." What was my next question to him? Literally, it's 5 minutes into the interview. What's my next question to him? Why are you spending $5,000 on an evaluation? 6 DUIs, guys. He has had continued use despite consequences. First DUI, you could have had too much to drink with dinner, not enough to eat, be a lady and not metabolize alcohol. I'm not saying it's okay, but it happens. Second DUI, not a mistake. Not a mistake. Why? Because every state in the United States, it costs you 48 hours in jail. Every single one. It costs you 10 grand for an attorney. And I don't know what you all do in North Carolina, but in Tennessee, we take your mugshot and we put it in something called a busted paper, and we sell it at the mini mart for $1. So we publicly shame your ass, okay? So those are consequences. That second DUI. So he looked at me and he said, you know, you're right. He saved $5,000. He went to treatment. He's still in recovery today. All right, so you have to know what the difference between dependence and addiction is. So when I write you that medication for 4 days, why do I only write it for 4 days? Because between 3 and 4 days is when the dependence process starts. That means when she stops taking it, she's going to get a little bit dope sick. Now, is she going to go full blown, sweating on the floor? No. But you all know this. You've had procedures. Some of you had your gallbladders out, back surgery, whatever. And you stop taking the pain medication, there's a few days there that you don't feel great, right? You're actually in dope sick. You're withdrawals. And then you get through it and you go on about your life. And that withdrawal period is solely based on the half-life of the medication. So a drug like heroin, short half-life. Short peak to dope sickness, short length of dope sickness, usually 3 to 5 days. OxyContin, long acting, right? 3 to 5 days to peak, 2 weeks to get through it. Try being dope sick for 2 weeks, guys. It's gonna be really, really hard. So here's the kicker for you prescribers out there. When you write her the second prescription, okay, there's a 65 to 70% chance she's still gonna be on that medication a year from now. And if you guys are practicing primary care, any of you, and you don't have a patient like I'm getting ready to describe, I'll be shocked. Do you ever have these charts come across your desk or across your computer where you're prescribing a controlled substance and you know something's wrong with it and you hold your nose and sign it anyway? We do it all the time. All the time. I want to teach students and residents how to not do that, right? I want to teach them how to identify those so we can help those folks, because all of us are guilty of it. I've done it numerous times. It used to be stacks of charts. I'd hold my nose, sign the script for another month. We have to stop doing that. We absolutely have to stop doing it. So the key inflection point is when I write her that second prescription, because there's going to be a 65 to 70% chance she's still on it a year later. So before you go writing that second prescription, you need to stop and ask myself, do I still need an opioid here? Is this still necessary? Right? So 600 milligrams of ibuprofen twice a day with 2 extra strength Tylenol twice a day has been shown to be as effective as 10 milligrams of morphine. Fact. Right? And there's a lot we can do. Our dental colleagues are doing really, really well with this one. Right? Their opioid prescribing has gone way down. If they need it, prescribe it. We're providers. I don't want the Fed sticking their nose in our business. But we have to ask ourselves, is it truly needed? Because pain is actually a symptom that something's wrong. And it's also a guide. So we need to ask ourselves that. So write her the prescription. You have 2 things here that bother me. 1, you have a family history. 2, you have the trauma. If you find yourself down the road when you get off this medication wanting it, or you find yourself wanting to get it from another doctor, or you're asking friends for it, please come back and see me. Nothing wrong with that, right? So what winds up happening is that the part of our brain that interprets physical pain doesn't separate physical from emotional pain. I didn't know that, right? So I've got a young lady here who has this history of trauma she's dragging around with her and has drug it around most of her adult life. And when she's on the pain medication for his leg, guess what? The emotional trauma feels a hell of a lot better too. And then her leg gets better and she stops the medication. Well, we didn't do anything to treat the emotional trauma, so it's back. So that impending sense of doom, that anxiety, whatever it is back. And suddenly she remembers, well, I didn't feel this when I was on the medication, so maybe my leg is, right? It's nothing wrong. It's just what it is, somatization, right? So she winds up going back on the pain medication, or borrowing it from a friend, or going to another doctor, getting it, right? I mean, that's what happens. And then after 14 days, she is going to be dependent on it. She will get dope sick now, and now she can't quit, okay? Or if she gets through the dope sickness and she has addiction, she develops cravings. The difference between dependence and addiction, guys, is people who are just dependent don't develop the phenomena of cravings. People who do have addiction develop cravings. And there's several things you need to know about cravings. 1, they're lifelong. I've been in recovery 20 years. I still have cravings for OxyContin. I still do. Right? It doesn't happen very often, and it doesn't happen near as bad as it used to, but I still have it. I've got 20 years worth of experience in how to deal with that. Okay? The other thing about cravings are they happen as little as 33 milliseconds. That's the time it takes you to blink your eye. So you're not even conscious that you're blinking your eye. Okay? How do you defend yourself against something you're not even conscious of? And I'm telling you, it takes a long time to teach patients how to do that. The first thing you got to do is not put yourself in that situation in the first place until you develop some tools on how to be able to deal with it when you're faced with it. So when I came back from treatment, I'd been in treatment for 4 months, and my nurses were great. My dean of my med school, president of my university were wonderful to me. And so this is back when patients used to bring the big bags of medicine into the office. I don't know if any of y'all remember that, but they did. So my nurses knew right off the bat. When they do that, they grabbed the bag before it ever got to me, wrote down the medications. I got a sheet of paper and medications, went back to the parking lot. All right, so those are things I put in place because I didn't want to touch it. I didn't want to see it because I didn't want to get triggered. Now, I don't have to do that anymore, but early on I did. So these are some of the things you can do. So you understand now the difference between dependence and addiction. You understand when I write that first medication, here's the length of time I'm going to write it for. When you do the second prescription, you're looking at a 65 to 70% chance they're still on it a year later. So what I want to do is I want to build a relationship with my patient. So if she goes out and she finds herself going to multiple doctors, finds herself getting it out of people's medicine cabinets, I want her running to me for help and not running away from me, right? That's what I want to do. And guys, I think that's about the best that we can do. It's informed consent, okay? And probably everybody in this room has been prescribed an opioid pain medication at some point in their life, more than likely. Have you ever had a talk like that with the provider who wrote it? Absolutely not. Here's what happens in her case. Surgeon puts a rod in her leg. Nobody comes to talk to her about the medication she's on at all. She's going to get a sheet of paper or they're going to send it in electronically and just say, hey, stop at the pharmacy and pick your medications up. That's what happens. All right, so she starts taking the medication, likes it, takes more of it, likes it better. Her life is getting better, right? All this emotional pain is going away. Medication runs out. She comes back to the doc. The doc just went to a prescribing course that told him, you better watch out, the feds are going to get him, so he cuts her off. So she goes to another doctor. And then they go through the same song and dance, and then she goes to a third doctor, and they go through the same song and dance, and soon she runs out of doctors, and she starts getting it out of people's medicine cabinets. Guys, 70% of first-time opioid users get the medication free from friends or family. Get it out of your medicine cabinet. They don't get it from a doctor. That's why drug take-back programs are so effective, okay? So she goes through all that. Finally, she gets at her wit's end, all right? She's spending all of her money on this. She's a soccer mommy, so nobody's suspecting her of anything, but she knows she's in trouble. She goes back to the original doctor and says, hey, I need some help. Here's what happened. The doc goes in, pulls up the prescription monitoring data bank, says, good Lord, she's been going to 5 doctors and 6 different pharmacies. That's doctor shopping, young lady. What do they do there then? You all know. What do? Kick them out. I just kicked out a young 25-year-old mom with opioid addiction and put her on the street, okay? And I didn't do anything to treat her addiction. And now she gets a hold of what she thinks is oxycodone, looks like what comes out of the pharmacy, only it's carfentanil, and she dies. And we scratch our head. That's a system's death. That death is on us. And these are the kind of things that we have to prevent. So I'd encourage you, before you write the pain medication, and I'm talking about any controlled substance, 2 through 5, all right? I would definitely look at the slot machine. Do they have a family history? Do they have a trauma history? If they do, they're at increased risk to misuse it, and they need to know it. And we're the ones that need to tell them, okay? And then we document that in our medical record, because I can tell you that I review records when we prosecute docs, and we don't take their license. We send them to prison, okay? They go to jail, okay? If that's in there, there's none of them going anywhere, right? They've given their patient proper informed consent, and they've done their due diligence. Problem is that almost nobody does it. It's actually my retirement plan. That's what I'm going to do when I retire. Just do that, because I promise you I can make enough money on it to do that. So that's kind of some things that you can do realistically when you're seeing a patient in 7 to 8 minutes in your office to at least risk stratify them, document in the medical record that I risk stratify them. They didn't have any risk factors, so I did this, or they had 2 risk factors, so I did this. And keep in mind, the second script is the key. Anybody got any questions about that? All right, it's not about drug screening. It's not about sending people to treatment. It's about understanding risk factors for the development of any type of addiction. All right, so let's talk about the brain here real quick. I love this. And if I've got any neuroscientists in the room, none of what I'm going to say is going to hold up to some PhD neuroscientist. And I really don't care, okay? I want you to be able to understand what I'm talking about. And I don't change this presentation. I've got a room full of doctors tonight, okay? Saturday, I'm going to be in the Rutherford County Jail in Tennessee. And I'm going to use the exact same talk. I'm going to teach them just like I do you all. Because the truth is that hardly anybody in the room understands what I'm getting ready to tell you. All right? And it's just a fact. I didn't know. So there's 2 areas of the brain I want to talk about. One is right here, and I don't know who came up with this picture of the brain. It's one that obviously we got a copyright on, and now this thing doesn't work. I bet I know why. Attaboy. Didn't have it on. All right. That's what happens when my computer goes down. My son said, did you unplug it and plug it back in? I mean, I finally do that now. So 2 areas I want to talk about. One is buried deep in our brain. It is our ancient limbic system. It is all about pleasure, right? Food, water, sex, okay? And I'm going to call it go. It's got a lot of different structures in there. All of them have horrible names that I don't care anything about. I want to talk about go with our limbic system. And then everything in front of the Sylvian fissure here, which is not on this brain, but everything that I'm pointing at here is the frontal lobe. We're going to call it stop. So I'm going to talk to you about go and stop here real quick. So the pleasure center, the go system of our brain, has two big functions. First function is it's responsible for our will and our desire to live, okay? How strong is your will and desire to live right now? What would you do to save your own life right now? You'd do anything. You're capable of anything. If I got rid of all the food and water in here right now, and we sit here and we looked at each other day after day, starving, all right, we're going to do two things eventually. One, we're going to drink each other's urine. You all know that. The second thing we're going to do is we're going to eyeball each other, see which one's the weakest, and that's the one that's going to get eaten first. That's how strong your desire and your will to live is. That is a limbic system, go system function. Here's what happens in addiction. That desire and will to live that is a function of the limbic system, the go system, is replaced by whatever the drug is. So now it's not your desire and your will to live, it's I've got to have this or I'm going to die. That's the message that the addicted person gets. And I'll tell you a quick story on that one on me. So I started off taking half of a 5 milligram hydrocodone on the way home from work one day. And I have a history of physical and sexual abuse when I was growing up, and I have a long family history of substance use disorder. My 2 sevens are sitting right there. It doesn't matter, I got MD after my name. Right? I wasn't a kid, I was in my 30s. I'd never done anything like this. And I picked that pill up on my way home from work, boom, threw it in my mouth. 5 minutes later, suddenly my life is better. My anxiety's gone, my depression's gone, my wife is better than I think she is. I'm still married to Karen. My kids are better behaved, my job's not as bad, right? That area of my brain with the emotional pain was anesthetized by the opioid, and that was it, buddy. Within 4 years, I was using 500 milligrams of OxyContin a day. How much is that? That's 100 Vicodin every day. And 8 milligrams of Xanax because I had to go to sleep. All right, 8 milligrams of Xanax is a boatload, at least for me it was. Okay, and somehow I didn't die. And guys, I'm not living underneath the bridge. I'm a professor in medical school. All right, I'm teaching medical students, medical residents. The 4 years that I used, the internal medicine department the students named me the best teacher in the school. All 4 years I used. All right, that's just how it is. All right, I had no idea about any of this stuff. I didn't understand how that worked. So I got up to 100 pills a day. We're going to Orange Beach, Alabama on vacation. I'm going to be gone 7 days. I need 700 pills. All right, and so I get my hands on 700 pills, which is hard. Okay, get my hands on 700 pills. I take off to the beach. All I got to do is take 100 pills a day and I'm going to be fine. Only I have addiction, and I can't do that. I took them until they ran out. I ran out on Thursday. So from Sunday to Thursday, I took 700 5 milligram oxycodone. So now I know I'm going to get Dopesick. So I said, I got to find a pill mill. Looked all around, couldn't find a pill mill. On my way back to the condos we were staying at, my kids are playing on the beach. I pulled into a Rite Aid pharmacy in Orange Beach, Alabama, right on the corner, right on the main drag. And I sat in the parking lot. I'm a country boy. Back then, I used to carry guns. I don't anymore, but I used to. And I sat in the parking lot and I thought, okay, I could write myself a script. I could do that, but the DA would catch me, okay? Or I can strong arm rob this pharmacy. And I had a loaded .45 sitting in my lap. Now, I'm going to ask you all this question. It's a tricky question for me. Do I look like the kind of guy to rob a pharmacy? I don't think I do. I've had audiences tell me before I do, but I hope not. All right, I don't. I wouldn't even know what I was doing, all right? And so how in the world could I think that? Because I was addicted and I thought if I didn't have this thing out here, I was going to die. How can a woman be pregnant and stick a heroin needle in her arm? Same thing. Same thing. It's how I got involved in addiction medicine to start with, was treating pregnant women. I heard people say all these terrible things about these young women who were pregnant and using drugs. And I said, what are we doing to treat them? We don't take them. Why don't you take them? Too much liability. So we're going to talk about them. We're not going to treat them. So I learned how to treat them. Okay, and I'm telling you, if you told me I can't do that anymore, I'm quitting. My women are strong. My women are resilient. They fire me up every single day. And the triumphs are great and the tragedies are horrible. And I love every second of it. And I get how come a woman can stick a needle in her arm with a baby inside of her, because if she thinks she doesn't have this thing, she'll die. And I understand it. I'm not saying it's okay. I'm telling you I understand it. And I also lived it. Now, luckily for me, I have, in recovery terms, what's called a moment of clarity. So I did not strong arm rob the pharmacy. I had on a Tennessee football shirt. I was in Alabama. They would have busted my ass before I got to the parking lot. So I didn't rob the pharmacy. I was dope sick for the next 4 days until I got back to East Tennessee. So I want you to know these things that I'm teaching you right now, they're real life things. You all know that. You know, you've seen women. I see newspaper articles. Woman in hotel, kid across the street in car. I know. I don't need to read anything. I know what happened. I'm not condoning it, and I'm not really mad about it. We got to protect the kid. I got to get to mom, because mom's best chance of raising that kid is if I can help that mom. right? It's going to change that kid's life because we separate that kid. You go into the foster care system, you have all that. Grandparents raise it, you've got that, right? That's if you can find the grandparents. Because now we know how many grandparents got the same issue, right? This is a generational thing. So I want you to understand that about the limbic system. Now, the second big function of the limbic system is responsible for our species going forward in time. What does our species got to do to go forward in time? Number one, we got to live to be reproductive age. Number two, we got to have sex. If we do that over a long enough period of time, our species will go forward in time. Does eating, drinking, and sex feel good? Hell yes, it does. If it didn't feel good, nobody would do it. If every time you ate this food that you ate just now, or you had sex, you threw up, you're going to stop doing both of them, and our species is going to die. Okay? So here's what happens. You get a little hun. I'm not going to go down the sex route. I'm 57 years old. I'm not stupid. We're going to talk about food here for a second. Anybody ever tried to lose weight? It's very hard to lose weight, all right? And so here's what happens whenever we're looking at, the whole food thing. We take terrible care of ourselves as healthcare providers, right? Most of you didn't eat breakfast this morning, and a lot of you didn't eat lunch, okay? You come in here, maybe you grab something out of the vending machine, and then you get in here, your body's telling you it's time to eat. You have a hunger pang, your blood sugar drops, you get a little sweaty on your skin. There's even an emotional component to it, right? It's called hangry, all right? So you've got all that going on, and you have these cues in your environment that's telling you it's time to eat. It's 6 o'clock, that's dinner time, right? So you develop cravings, okay? And so you have euphoric recall, and you remember the last time you felt like this, you ate, you felt better, so it's going to drive you to eat. Now, if I want to run your cravings up even more, I'll open those doors back there, I'll put food out in the lobby, and I'll blow the smell in here, right? And I'll run your cravings up. Next thing you know, you all will be snaking out that way, bring the food in here, just like you all did, only they brought it to you. All of you took a few bites. Here's what happened in your limbic system as you took those few bites. Your body started to make its own morphine, its own oxycodone, its own hydrocodone. They're called endorphins and enkephalins. Those endorphins and enkephalins attach to the opioid receptors in the limbic system, GO system of your brain. It leads to the downstream release of dopamine. And everybody in this room loves dopamine. It makes you fat, happy, and satisfied, okay? And now that dopamine's taken back up into the nerve ending, waiting on the next impulse to come along. That's how come you do it. It feels good. It gets rid of the hunger pangs, and the thing that drives it is dopamine, all right? And that is a good thing. Is that always a good thing? No. What if you're trying to lose weight? It is not a good thing, okay? So up until, 7 years ago, I weighed 251 pounds. I tried every diet in the world to lose weight. All meat, no meat, all carbs, no carbs. I was a vegetarian one afternoon for about 30 minutes, tops. All right, lost weight on all of them, put it all right back on, and I decided I was going to do this. I want you to keep in mind I'm a trained physician. I'm going to watch what I eat and exercise, and I'm going to do that every day, okay? So I work at a little gym called Orange Theory because they're all over the country, and I burn about 800 calories in an hour. On the way home, I work out at 6:15, I pass a damn Krispy Kreme donut, okay? Now, what is the limbic system of my brain telling me when I see the Krispy Kreme? Because I dream about it. I got a visual image of that thing in my head right now. What's the limbic system of my brain telling me to do? Go get the donut. Limbic system is about food, water, sex. It's all about reward. It's go. Luckily for me, I have a fully functioning and connected stop system. It's called the frontal lobe. Insight, judgment, and empathy. What's my goal? Lose weight and get in better shape, okay? So my limbic system is screaming, go get the Krispy Kreme donuts. I'm 56 years old, or 57, damn it, I'm 57. All right, got a birthday. So the limbic system in my brain says, oh, hang on a second, Steve. You just worked out for an hour, you burned 800 calories. Each one of those Krispy Kreme donuts that you're thinking about right now has 220 calories and 20 grams of fat. Not bad, I'm eating 4. So that's 880 calories, 80 grams of fat. What happened to my hour-long workout? Should have stayed in bed. Guys, I teach you that. It's funny, but we've all experienced it, and it's how we make decisions all day long, every day. You look at a series of choices that have benefits to them, and then you pick the one that gives you the most amount of benefit with the least amount of consequence, and that is a balance between the stop and go systems of your brain. I wish they'd have taught us that in neuroscience in med school. All right, I get that. I understand that, okay? So Steve, what's that have to do with anything? The stop and go systems of your brain are not neurologically connected until you're 23 years old if you're a woman and 25 years old if you're a man. Those of you who are teenagers, that's why they're stupid. Okay, they're not stupid. They make bad decisions. They make bad decisions because they're driven by their limbic system with very little higher order input coming from the frontal lobe with regard to insight, judgment, and empathy. Now, when they get to be 23 and 25, they make better decisions. If you think what I'm not telling you is true, look at when their car insurance rates go down, 23 and 25. Right? If you think what I'm telling you is not true, what does Krispy Kreme donut do to try to override your frontal lobe of your brain? They blow the damn donut smell out in the street. All right? And then if you can overcome that, they got one last line of defense. Everybody knows what it is, right? That blinking red sign that says hot donuts now, right? So what they're trying to do, they're trying to get your lizard brain to overcome the frontal lobe of your brain and get you to pull in there and waste your 800-calorie workout. Guys, that's how this works. What does that have to do with addiction? The connections between the frontal lobe, the go and stop system, are arrested in development at time of first drug use. 25-year-old belly button age, giving me answers that are making me crazy, right? Crazy. I'm like, God, how can you answer me like that? It's the stupidest answer. You know, what are you thinking? I don't get mad anymore. I stopped. How old were you when you started using? Steve, I started using when I was 13 with my dad. I don't know what you all see when you have substance use patients. My patients started using in their own families, almost all of them. So my patient may have a belly button age of 25, their brain age 13, okay? And I know how to deal with 13-year-olds. Okay, I know how to do that. I've got the next slide, unfortunately, is not going to show this as well as I like, and so I won't use it at all. I'll have to describe it to you. So if you take a PET scan of a brain, I've got a radiologist in here, I hate that. So when I'm trying to describe PET scans to people, I describe it like this. PET scans look and see where radio labeled sugar goes. I can teach that in jail, right? And so if you had a way to attach something to a sugar molecule, you stick it in somebody, you can light them up, you can at least see what's functioning, what's working. So that's good enough for the people I teach. But Dr. Nora Vokow did a study several years ago where she looked at normal brains, okay, lit them up, uptake through all lobes of the brain. She looked at a second group of brains with PET scans that had been detoxed off of drugs for 10 days. So you come in to me, now you're pregnant, you're shooting heroin, okay? I bring you in, I detox you for 10 days. Say, okay, you're not gonna get Dopesick anymore, have at it. I send you back out into the world. First of all, how long does she last? How long does she last? She'll use in the parking lot. Standalone detox is the worst thing that we do for people with substance use disorder. It doesn't work. And not only that, they're off drugs for 10 days, so their opioid receptors go down. If they go back to using the same dose they did before they went in, they die of an overdose. We got to stop doing that. Only 8% of the people who get detox go to a higher level of care. Okay? But I send her back out into the world after 10 days. And now I've got a PET scan of her brain. Guess where there is no uptake in her brain? The frontal lobe. It's essentially shut down. What is functioning? Her reward system is functioning. All the cues in her environment are functioning. And the next thing you know, she's got a needle in her arm. That's how it works. Let's look at brains with PET scans 100 days out. Guess what's starting to come back? You'll see little flecks of it. The frontal lobe starting to come back online at 100 days. How long does it take the frontal lobe to come back online after you stop using? Anybody know? Fully. 2 years. How long are traditional treatment programs? 28 days if you're lucky, right? Who defined that 28 days, by the way? The insurance industry. Had nothing to do with medicine. It was what the insurance industry would pay for. We send kids away all the time for 28 days of treatment and expect them to come back and not use drugs anymore, and it's a farce, and we're killing them. And we got to stop doing it. Because at 28 days, they don't even start to begin to have their frontal lobe come back online. And they've got the same cues in their environment. We've done nothing to treat the underlying driver, which in most cases is trauma, and they're almost all going to relapse. We got to stop doing things that are ineffective. Why do I love drugs like methadone? Why do I love buprenorphine? Why do I love naltrexone? Those drugs quell cravings. People relapse because of cravings. All of y'all relapsed a little while ago. And if you eat breakfast in the morning, you're going to relapse again. If you do what you did today, you're going to do it tomorrow, you're going to relapse around 6 p.m. tomorrow, right? Here's the kicker. Somebody who's addicted to drugs, their cravings are 10 times stronger than your cravings are for food when you're hungry and water when you're thirsty. So when people find out what I do for a living, they say, well, I'm a physician. And I hate the next question. What is it? What kind of physician are you? I take care of women who are pregnant and use drugs. And you should see some of the looks I get, right? And so every time I say that, they say, well, they need to stop doing that. They need to quit. They're hurting themselves and their babies. And I'm like, I swear to God, I thought of that way early on, okay? It's not how it works, okay? It's not how it works. And I say, you're right. I'd like for you to stop eating. Theoretically, it's going to be easier for you to stop eating, and I'm not talking about today, I'm talking about stopping eating, than it is for them to stop using, because their craving for this thing out here that they think they'll die without is 10 times stronger than our cravings are for food when we're hungry and water when we're thirsty. But we can teach them. I haven't had anything. I'm not on any of those medications, but I had the world's best care. So you understand about cravings, you understand that it's the driver of relapse, you understand the interplay between the frontal lobe and the reward system and why it matters, right? I think we got everybody there. All right, anybody know who this guy is? Vincent Felitti? To me, he should be on the Mount Rushmore of medicine. Felitti is a weight loss doctor in California. Worked there in the 1980s, 1990s. I think he still practices, actually. He's a little older now. And he is the lead author of the ACEs study. So what he had morbidly obese women in his clinic, mainly a few men, but mainly women, and they were 500-600 pounds. This is before we started putting them on TV and making fun of them, okay, which is what we do now. But he had these morbidly obese women. Some of them would lose the weight, put it back on. Others would lose the weight and not put it back on. He wanted to know the difference in between the two groups. He thought it had to do with unresolved trauma. He came up with a list of 10 questions, and one question got his attention, and it was this one. How much did you weigh the first time you had sex? And the answers he got were in the 40 to 50 pound range. Okay, what question should he have asked? How old were you when you had sex? All these women were victims of sexual abuse within their own families, basically as adolescents. Okay, and this is an important point right here. What's their drug of choice? Food, right? Guys, the drug is not the problem. The drug is actually the answer. Okay, if I can eat enough, I can make myself physically unattractive to my perpetrator. Okay, Stephen Loyd sitting at that red light in Johnson City when I picked that first oxycodone up, or hydrocodone, it was not the problem. The problem was me. The problem was my genetics. The problem was my trauma. The problem was I had no idea how to deal with either of them. Okay, the drug was the solution. When I took the drug, I felt better. I remember having this conscious thought. I remember thinking, oh my God, I found a cure for my anxiety and my depression. That's what I thought. I had a psychiatrist sitting where you are one time, and he jumped at me and goes, opioids are not a treatment for depression. I was like, I know that, asswipe. I get that. That was not, I mean, I still keep hoping to see him again one of these days because I got way more confidence now. Opioids have been used to treat anxiety and depression since the time of Hippocrates, for literally forever. Okay, but the problem with it is that you develop tolerance to it, right? And then you have to have more and more for less and less effect. So it is not an effective treatment at all, but it absolutely works. It absolutely works by numbing the areas of your brain that are causing difficulty. So for Steve, that oxycodone or hydrocodone was the solution. For these women, food is the solution. As long as we keep having efforts to get rid of, try to get a handle on any kind of drug crisis, and we approach it totally from the supply side, we are going to lose. Doesn't mean we don't need to try. We absolutely need to try, but until you start to address the drivers of addiction and demand size, you're going to lose 100 times out of 100, and we have done that literally for years and years. So Felitti, lead author of the ACEs study, he got these 10 questions. He unleashes it on the Kaiser Permanente health system in the early 1990s, and what it shows is that when you get to an ACEs score of 4 or above, your risk of almost everything goes almost straight up, right between 4 and 5. And what do I mean almost everything? Real diseases, diabetes, hypertension, multiple types of cancer, SUD, behavioral health disorders, all go almost straight up with an ACEs score of 4. And I can tell you this, guys, people in general don't get into long-term recovery without addressing the underlying childhood trauma and sometimes adult trauma. They just don't. And there's great treatments for it. So when I went through drug treatment back in the day, and I didn't tell the story the same way this morning, but it is the same story and it's consistent. I just didn't go into this detail, but I got time right now. So there was one secret that I kept through my treatment for drug addiction. I was not going to tell anybody about sexual abuse. That was not going to happen. Okay, and I didn't say a word about it. And I got 10 years deep into recovery. My life is going straight up. I've come back. I've run our residency program through an ACGME cycle. I've run all the residency programs in a VA. I had 22 or 23 residency programs that I ran. I became the chief of staff for the hospital. I get hired in Nashville. I was our state's first drug czar. Right, my life is going up. And in the background, I had this underlying sexual abuse I never said anything about because it didn't matter. That was a long time ago. I pulled myself up in my bootstraps, so I'm just going to let that sleeping dog lie. And I was driving from Crossville to Nashville. It's about an hour and 15 minutes. And I was driving, headed home for the day, and I started having PTSD symptoms. I was almost 50 years old. I'd never had anything like that in my life. I couldn't drive. I was flashing back. I was crying. I had to pull off the road. I called my sister, who grew up in the same house I did, with an abusive mother who beat the hell out of us with everything that you can think of: sticks, ball bats, tobacco sticks, into shotguns, rifles. I mean, me and my sister were beat to a pulp. My favorite uncle started to molest me when I was between 4 and 5. It got worse as I got older until I got big enough to keep him off of me. And so I started having flashbacks. I said, Beck, I'm having flashbacks. She goes, you're going to have to go to a doctor and get put on medicine. I said, that's not happening. So about 3 months later, I wound up on the edge of my bed in Nashville with a loaded .45 pointed at my head and the hammer back right there. I was going to end it. And I thought of two things. The first thing I thought of was, who's going to find me? And I don't know why I thought of that, but I did. And it bothered me. And the second thing I remembered was to ask for help. And so I laid the gun down. I called a friend of mine. He says, Steve, the best place in the world for that is in Dixon, Tennessee, believe it or not. And there's a place there called On-Site. They treat everybody, members of the royal family. Every country music star in Nashville has been through there at some point. And so I just got in my car and drove there. And it changed my life. I did something called EMDR. Never heard of it. No clue what it was. And they told me what it was, and you can see my personality. I've got a tad bit of cockiness and maybe a little bit of ego here and there. And I looked at that, and they told me, so you're going to put this flashing light in front of you, and we're going to walk you back through some scenarios in your life, and you're going to experience those scenarios without the fight, flight, freeze, or appease response. And I was thinking, that may work for your average bird, but I'm pretty damn smart, so I don't think that's going to work for me. And I actually said that out loud. Boy, I'd like to get that back. Yeah, because the therapist is a good buddy of mine now, and he brings it up at least 2-3 times a week. But at any rate, it was amazing. It was amazing. I mean, after the first session, I already knew that things were different. And after multiple sessions, I can now talk about it, and it's not the boogeyman in the closet. It still happened. Nothing went away. But I don't have that freeze response, that flight response, that tense. I slept under my bed until I was 17 years old. I slept under the bed. The only time I didn't sleep under my bed is when I had friends over. I never told anybody that, right? You're not going to tell anybody that. But I was so scared of nighttime because of what happened at night. And how much was 4 weeks of treatment at On-Site? Anybody know? It's $50,000. $50,000 cash, no insurance. They don't take insurance. And I almost hate knowing it exists. How come I hate knowing it exists? Because my girls ain't going to get it. It's not accessible. I keep trying to talk to them. I'm like, hey, all y'all have got a bunch of money. How about scholarship in a few of my girls? Right? Because my girls have been trafficked by their own family. I almost never get one of my girls that hadn't been trafficked by somebody. And most of the time, it's their own family. Can you imagine selling your daughter for drug debts? Me either. I had no clue. I was living in this world where everybody's a doctor. They all live in my neighborhood. Hell, we all went to med school. And I started seeing this, and I couldn't unsee it. I mean, I could deny it, but I couldn't unsee it. And so when I look at our treatment system now, there's two treatment systems out there. There's a treatment system for people who have resources, and there's a treatment system for everybody else. When I went to Nashville, my dad intervened on me. In 2004, we went down, they took one look at me, and they said, you got to go to a detox unit. And guys, I didn't know what detox was really. I mean, I had a little bit of idea, but not much. And so I go into detox unit, there's 24 kids on my floor, nobody knows I'm a doctor. How many of those 24 kids got to leave that detox unit and go to a treatment center? One. You're looking at him. And the rest of them went back to the street after 5 days. Right back to the street after 5 days. And these are kids. They're absolute kids. I was in my mid-30s. I had an MD degree. Hell, the president of my university and the dean of my med school paid me every day I was gone. I never missed a paycheck. All of them got fired and never had jobs to start with because of their substance use and where they grew up. I hear people say all the time, oh, you got to want it bad enough. That one drives me wild because I'd sit in there at night. None of them knew what I did for a living. I looked just like they did. And so we would sit there at night, and if one of them was getting out the next day, right, they would try to come up with a symptom where they got to stay one more day. I never could forget it. I can't forget it now. I think about it every week. I think about that because they don't have access to the treatment system I had access to. I'm a turtle on a fence post. I'm here because I stepped into a system of care that put me here. They didn't. And I don't know how many of them died. The little girl next to me was 19 years old. She lived in Mount Juliet, which is where I live now. She was a prostitute in Printer's Alley in Nashville, right downtown. She had these big abscesses on her arm. She had HIV and Hep C. Okay, and so the day before I left, I gave her my pillow. I had the only real pillow in the whole unit because my college roommate brought me a real pillow, so I gave it to her. She went back in her room, and she came out, and she goes, hey, Steve, I want you to see this, and she handed me a picture. And it was her at her junior prom in high school, and she was pretty as an angel. And I know that she went right back to where she came from after 5 days. And that's why I come. It's why I started yesterday morning in Las Vegas, Nevada, and I'm in the Outer Banks of North Carolina today. I flew all night, all right? I didn't sleep a wink, and luckily for me, I had about 70 high school girls basketball players on my cross-country trip, and they were very calm the whole way, all right? They all wanted to sleep. And so I did it for this reason that I'm talking to you about right now. The treatment systems are not the same. We have to understand that. I hate having to use medication. I want everybody to get what I get. It's not going to happen. Medication will keep them alive. If I keep them alive long enough, I can get to the underlying drivers of addiction and we can help them. We can keep them alive. Okay? It's just the facts. It's just the way it is. I wish we had stuff better, but right now we don't. And methadone and buprenorphine had a 70 to 75% mortality benefit. They quell cravings. Cravings are what causes relapses. That's why I love medication. So what I'm getting at here are the underlying drivers is all around childhood trauma and sometimes adult trauma, and it's highly treatable. And the treatment is effective, and it's out of reach for the majority of the population. By the way, why didn't I get fired? Why didn't I just get kicked to the curb? I cost too much money to make. Citizens of the state of Tennessee's tax dollars paid for my medical education, okay? And so I cost too much money. So it's better to take Steve, put him over here, fix him in this system. I got 90, 110 days, well, total 100 days of the best treatment in the world. I got 5 years of aftercare and follow-up, which, by the way, I continue today. So I'm now at 19 years, 7 or 8 months of aftercare and follow-up. Who gets that in the world? Nobody. Nobody. We know how to do this. We're not willing to stick the resources to do it. And that's why we've got to do some other things. And that's one of the reasons that I'm such a medication proponent. So when I saw this slide, the fact that I have a biochemistry slide should be a sign of the apocalypse because I hate biochem. But this is my favorite biochem slide. So let's take a look at it real quick. When I saw this, the light bulb above my head went off. If we look at the effects of chronic stress, any type of chronic stress, causes our pituitary to release ACTH. ACTH tells our adrenals to make cortisol. Look what cortisol does to dopamine. It eats it. Why do you all feel good? You exercise, spend time with a loved one, hammer a piece of cheesecake. All right, why do you feel good? Dopamine. What if you were walking around with a chronically low level of dopamine because of the effect of the chronic stress of cortisol on it? On an emotional scale, I use Winnie the Pooh. Tigger's here, Eeyore's here. Which one are you closer to? Eeyore. All right? And then, by happenstance, the doctor writes you a prescription that normalizes this rascal here. Voila, you felt normal. The first time I used, when I put that pill in my mouth in my truck and I got home, guys, I wasn't high. I wasn't woo. I felt normal. First time in my life. First time I didn't have that overwhelming anxiety feeling in my stomach and my knees. And I thought I'd found a cure for my anxiety and my depression. When you talk to somebody that has opioid use disorder, ask them about the first time they were used. They'll be able to tell you. They'll be able to tell you the wallpaper of the room they were in, even if it was 25 years ago. They'll be able to tell you the pill. They'll tell you if it had a number on it, what color it was, and then ask them how it made them feel. They're going to give you this answer. 2 answers they'll give you. One is it made me feel normal, or 2, it gave me energy. That's what you're going to hear. Okay? They weren't slopped over. They weren't humped over. They weren't, seeing, lava lamps. Okay? They felt normal. And I think it's because of this. It makes sense to me. At least that's what I teach because I get it. The third 7 is the social opportunity. I told you I would show you the Porter and Jick letter, and here it is. And the first thing you realize it is not a clinical study. There is nothing double-blind, placebo-controlled. It is a letter to the editor. He said we had 39,946 people in our hospital over a period of time. It's actually Mass General. And 11,800 of them got an opioid while they were here. We followed all 11,800 of them when they got out, and only 2 of them became addicted. Okay, first of all, that's not even comparing apples to apples. Long-term outpatient treatment with opioids is weeks and weeks and months and years. You're in the hospital for a few days. And so this is the reason that you see pharmaceutical companies losing lawsuits because they absolutely mispromoted the safety aspects of the drug OxyContin. And then the other people says, oh, we didn't do that, right? But you jumped on because insurance companies a lot of times wouldn't pay for a branded drug, but they'll damn sure pay for the hydrocodone over here that Mallinckrodt charges 5 cents for. Okay, so the way I sold it in the expert cases, because the money that we won $55 billion. I was the leadoff expert in the case. My job was to draw a line of causation. I had to show that the mispromotion of OxyContin led to today's heroin and fentanyl epidemic. That was my job, and that's what I did. And you can actually draw that line because there's a direct correlation to that. So they promoted this. A rising tide raises all boats. Okay. So not only did the OxyContin sales go through the roof, so does Mallinckrodt with all their generics. And then you had Johnson & Johnson, the people who make our baby shampoo. Also the biggest poppy plant grower in the world is Johnson & Johnson. People doesn't know that. And they also had this little drug called Opana. Opana is oxymorphone. Oxymorphone was one of the most abused drugs in the history of the United States. Johnson & Johnson absolutely knew it, and they released the drug really at the height of the pill opioid epidemic between 2008 and 2010. All right, so if you have kids, this is the thing that needs to keep you up at night. So when I first started hearing about fentanyl, I thought, what in the world is fentanyl? All right, how are they diverting that stuff out of the hospital? It's very hard to do. It's right. It's in the OR. It's in ED. How in the hell you get it out of there? We're not talking about diverted fentanyl. We're talking about powder fentanyl that's mainly, for the most part, made in China, brought into the United States, and pressed into pills that look just like what you get out of the pharmacy. Now, when I first started seeing fentanyl, first time I ever saw it, we actually bought it, an undercover agent bought it, was 2015. And if I looked at it, it looks like an oxycodone. It's yellow, it looked like a school bus, right? That's what they call them on the street, school buses, 10 milligram Percocets. And I could see impurities in it. Okay, I could actually pick that one out. But I've done it a lot, and a normal person is not going to be able to do that. But you got to remember, back then they're using rudimentary stuff. Their pill presses are homemade, getting stuff from Lowe's, making pill presses. Now the pill presses are pharmaceutical grade. The last video I have of a seizure in Tennessee was one that puts out 25,000 pills an hour. And I can't tell the difference. I can look at them. It's actually these right here. I can't tell the difference. So what's the deal here? Well, this is an oxycodone. Oxycodone is 1.5 morphine equivalent. So if you have 10 milligrams of oxycodone, a 10 milligram Percocet, that is 15 morphine equivalents. Okay? Only this is not oxycodone. It's carfentanyl. And depending on the analog for carfentanyl, it's 100 to 10,000 morphine equivalents. Long and short of it is you take this and you die. And that's what's killing people now, okay? And fentanyl is in absolutely everything. You've probably been a little bit isolated from it here, but I guarantee it's here now. Last time I was here, it was not here. It is for sure here now, okay? And it is in absolutely everything. It's in stimulants. If you've got people using methamphetamine, guarantee it's got fentanyl in it. Bet my life on it. Cocaine, it's got fentanyl on it. Scariest one for me, vape juice, right? Kids, we had 7 overdoses in a county in Tennessee on a vape juice, right, that was adulterated with fentanyl. Okay, you don't even have to use opioids anymore to die of them. And this is why I think that we have to change our strategy. I don't drink either. I've never been a successful drinker. But if I decide to drink tonight, I'm up here, nobody's going to see me, all right? So I can start if I want to. I got money. All right, if I decide to start drinking tonight, I'm 57. I'm pretty healthy. I don't have any chronic medical conditions. It's going to take 20 years of hard drinking to kill me. Let's have a car wreck. If I decide to relapse tonight and stop out here on the street and get a pill, I'll die this afternoon. And everybody in the room knows it. We can't use the same strategies that we've used in the past. We've got some old AA guys. I went over and gave them some money and told them to go and do a little drinking and find their bottom. I want to punch those dudes in the mouth. All right? You do that now and you send a kid back to the street to do a little experimentation. They get a hold of the wrong pill, they die today. Guys, the urgency has gone way up on this because of fentanyl. All right, so I'm actually going to finish early. We're going to look at 2 different patients here, and I want you to understand the system of care they step into. So I opened a methadone clinic in Cocke County, Tennessee. Guys, I don't understand the first damn thing about methadone. Nothing. I knew nothing about it. I had a judge up there, Dwayne Sloan, who I work in his drug court. He wanted all 3 types of medication in his court. He wanted a provider he could work with, and so I opened a clinic. Methadone is a terrible drug. It has a long half-life. It has 1.5 million drug interactions. I got a whole room full of pharmacists over there, and I'll bet you between them, they can't come up with half of the drug interactions of methadone. And they can come up with a lot, and it's still not going to be half. It is a long list. It is a terrible drug. Some of my kids are using so much fentanyl, it's the only thing that'll keep them alive. And guys, I'm going to keep them alive. I don't care. We get something better, I'll use it. Buprenorphine won't hold them. Tolerances are too high. When I went into Vanderbilt, my CAL score, y'all know what a CAL score is? Clinical opioid withdrawal scale. It is a measure of how dope sick you are. My CAL score was a 12. I sweated through 9 t-shirts my first night in rehab. 9. I thought I was dying. The kids I get today's CAL score is 30, 35. Tolerances like I have never seen in my career. And it's all because of fentanyl. So I opened a clinic in Newport. This is patient number 3. Cocke County, Tennessee is the 2nd poorest county in the state. People who aren't from Tennessee know where Dollywood is. Gatlinburg, Pigeon Forge. It is the county right next to that before you get over in towards Asheville, North Carolina. Okay? Cocke County is famous for 2 things. Fighting roosters and moonshine. Okay? Only 8% of the population of Cocke County has any post-high school education at all. It has been riveted by the opioid epidemic, just absolutely riddled. Patient number 3 is 33 years old. She has a scar from here to here. Why would a 33-year-old woman have a scar from here to here? Open heart surgery. So she's injecting heroin. She gets endocarditis. She goes to a large academic institution. They can't get her endocarditis under control with antibiotics, so they crack her chest open, put a valve in her, close her up. She's in the hospital 2 weeks, spent 5 days in the cardiac care unit. How much was that? Had to be $500,000, right? At least, okay? And when they discharged her, I don't know what her diagnosis was, but I can guess. I bet it's infective endocarditis status mitral valve replacement. I bet that's her diagnosis. And that's not her diagnosis. What's her diagnosis? Her diagnosis is substance use disorder, secondary to opioids, severe with a high risk of relapse and overdose, complicated by IVDU. That's her diagnosis. So when they discharged her from the hospital after spending all of that money on it, they did not address the reason that she came in. You already know the brain stuff. How long did it take her to stick a needle in her arm? In the parking lot of the hospital that she left, she did not get out of the parking lot. And people go, golly, Moses, how's that possible? She damn near died. Can't she see that? No. She doesn't have insight, judgment, and empathy. That's not something to look for. Y'all know what fentanyl test strips are? And I like fentanyl test strips, okay? So the rationale is I got this test strip, and I'm sorry, you're a radiologist, but you're also a part-time dope dealer. All right, so you're out there dealing dope. And he doesn't look like it, all right? Too clean cut. So you're out there dealing dope. You got heroin, okay? And the heroin could have fentanyl in it. I'm buying it from you. My logic as a healthy human being says if I got a fentanyl test strip, I can test your stuff. If it's got fentanyl in it, I'm not going to do that because I'm going to die, right? And that's how we're supposed to use fentanyl test strips. That's not what happens at all. Dope dealers tell me if I don't have fentanyl in my stuff, I can't sell it. Why? Because people want the best. They're driven solely by their reward system. They have no insight, judgment, and empathy. They don't care that they can die. That's not going to be them. They don't understand that. They test it. You don't have it. You do. You're the one that gets the business. All right? And I'm not against using fentanyl test strips. I'm telling you, we have to stop applying logic of our normal brains to the brain that is affected by addiction. It's not the same thing, guys. If it was, the woman would stick a needle in her arm, because tell me a mom that wouldn't die for a baby. My women are the same way. When they get into recovery, they take a bullet for their baby. When they're using, they'll stick a needle in their arm when they're 9 months pregnant. And I know why. I know why. All right, so I've been doing this for a while. I know where to look, okay? So I get her in. She gets out of the hospital. She starts using again. I get her. She's patient number 3. I look everywhere, right? Subclavian, I look at breast, in the groin, genitalia, right? Everywhere. Women like to shoot between toes, underneath watch bands, underneath rings. I know what I'm doing. I didn't look at her shin. I'd never seen anybody injecting her shin. So she'd been with us for a couple of weeks. She comes in and says, Dr. Loyd, I want to show you this. Pulls her pant leg up. Me and my nurse are looking at it. Everybody in the room knows this needs to be in the hospital getting IV antibiotics. This is bad. And she has an artificial metal heart valve as well, okay? So we're at big time risk here all the way around. And I said, you need to be on antibiotics. She says, I was on antibiotics. Same academic institute that she went to before, put her in there. She's using 5 to 6 grams of heroin and fentanyl per day. They start giving her IV antibiotics. What happens to her after she's been there for a day? She gets dopesick. She gets sick. Hospital doesn't know how to treat it. We don't believe in using these drugs. They're treating it symptomatically. Well, we'll treat your diarrhea with this, and we'll treat your aches and pains with this. You might as well be giving her ice water. It's not going to help her. So she starts pulling at her IVs and gets agitated. I'm probably the only one in the room that's ever been dope sick. And I can tell you, you wouldn't wish it on your worst enemy, okay? It is absolutely the worst feeling I've ever had. So she's pulling at her IVs. How did the hospital staff react to that? Kicked her out. Not AMA, kicked her out. She has an 11-year-old son that she does not have custody of. Does she need custody of her 11-year-old son? No. We have to protect the 11-year-old son. Does she deserve an opportunity? Damn straight. As long as I'm around, she does. So that's what we're trying to do, and they put her on the street. I said, we got to get you on antibiotics. She says, I'm on antibiotics. I said, okay, what are you on? She said, Clinda something. I thought, okay, decent, clindamycin, not bad. Bring it in tomorrow, because they got to come to clinic every day. So she comes in the next day, and she has clindamycin, all right. It's in a box. It's this big. It's blue, and it's got fish on it. It's clindamycin for guppies. She had Googled skin infection. She had Googled antibiotics for skin infection and figured out she could buy clindamycin at the pet food store without having to go and be shamed by a healthcare provider. Now, the problem with that is a guppy weighs about 1/10 of an ounce. My patient weighs $1.75, okay? So we had to get her on the $4 Walmart list with 2 antibiotics. We treated her for about 12 weeks. It scarred, but it cleared up. Just a few months ago, she got her second day of supervised visitation with her son. That's a good thing. Does she need her son back now? No. She doesn't have the tools. Does she deserve an opportunity? Yes. I point this out because, guys, this is the system of care that your patients are stepping into. If you don't think people are kicking people out of the hospital right now for stuff like this, you're living in a dream world. And I passed the hospital here, and I'll bet you our hospital here has done it too. All right? Not a very big one, okay? But I guarantee you that's how they do it. And if you all have a kid that has this problem and you think you're going to be treated differently because you look the way you do, guess what? That ain't going to happen. Then you're going to get treated the same way. One of the things that blew my mind when I started treating pregnant girls were how they were treated when they went to deliver their babies. It absolutely blew me away because they would come back and they would tell me these stories, and I was like, oh, come on, that can't happen. People don't do that. And so finally, I'm an internist. I just went to the hospital and saw them while they were there on the OB ward. They don't know me. So I would go in a pair of cut-off shorts and my T-shirt and my hat on backwards and visit them. And I would hear staff come in, and I heard how they talked to them. I was appalled. I couldn't believe it. And I went straight to the CEO of the hospital. I said, hey, this has got to stop. These were not bad providers. These were not bad nurses. They had no understanding of addiction at all. And so we started training. We did around-the-clock trainings for weeks, and the attitudes changed, and almost everything changed with the attitudes in the nursing staff and how these patients were treated. Guys, it was a lack of understanding. Most people who get into medicine doesn't get into medicine to be mean to people. They get into medicine to help people, right? And while their attitudes wasn't where I wanted to see them be, they had no understanding of what they were dealing with, and they were taking the tough love approach, which doesn't work. I've never seen it work. I don't use it. I don't do it. There's a bunch of people out there that do. I don't see that it works. I meet people where they are no matter what, and no matter how many times it takes, and I don't kick people out. Where do they go when you kick them out? Street, they die. I do not kick people out. So she is doing well now. We still have her as a patient. So I started treating pregnant women back a long time ago when nobody else was treating them. I didn't know anything at all about treating pregnant women. If you ever told me I would know as much about contraception as I know right now, I would have thought you had lost your damn mind. Okay, I knew absolutely nothing about it. But guys, if we're going to prevent babies from being born drug dependent, why aren't babies born addicted? They're not born addicted. They're born dependent. Why? Because babies can't have continued use despite consequences. Babies is purely physiologic. Okay, babies are born dependent. If we're going to figure out how to prevent drug-dependent babies from being born, we have to utilize voluntary reversible long-acting contraception. And it has to be in a way that has no barriers whatsoever. So I was trying to figure out what the barriers were in Tennessee, and so I do what I do. I just picked up the phone and started calling. So he said, you can get contraception at the health department. I said, good. Picked up the phone, I called the health department. I said, hey, I need to get my girlfriend on birth control. And my wife was surprised by that. But at any rate, they said, yes, we can do that. Appointment in 2 weeks. I said, good. Will she leave there with birth control? No, we have to do a pap smear. The AMA stopped recommending pap smears to put people on birth control in 1972. Now, we are in Tennessee, so that means we're a little bit progressive because that's only like 50 years. So I felt pretty good about that. But you got to come back another 2 weeks to get the actual birth control. So I've got a patient who's using, and I'm going to ask him to go to 2 appointments over 4 weeks. What are my chances of that happening? No way in hell. So what we wanted to do is we wanted to make access available to women who were childbearing age and incarcerated, and let them opt into a class to learn about contraception because they understand almost nothing about it. All kinds of misconceptions about IUDs. I'll be able to feel it during sex. It'll poke. It'll feel all of these things. And so we had a class. They could opt into it, not mandatory at all. And then at the end of the class, if they wanted to opt in, we had the OBGYN department from the University of Tennessee come in, put the shots in their arms until we could get devices in them when they came back to follow up. And in 1 year, the 2 counties we did it in dropped their NIH rate by half. And that's been maintained the whole time. All you got to do is change the pathway. But you get politicians say, well, you got to have some personal responsibility. Okay, I get all that. What do you want to do here? Do you want to prevent babies from being born drug dependent, or don't you? And if you do want to do it, then this is how you do it. You have to take it to them. You can't have barriers. And women aren't going to go to 2 appointments over 4 weeks, guys. It's not going to happen, at least not in my lifetime. So I started treating pregnant women. I love it. I still love it today. When I left the state of Tennessee, as the drugs are, I went to a place called Pier in Murfreesboro because they were going to let me start a program inpatient program for pregnant women. First one we ever had in the state of Tennessee. And I loved it. This is patient number 2, Brooke. My friend Brooke was living in Central Ohio. She was 25 years old. She has a long history of substance use disorder. Her dad had drug addiction when he was younger, and matter of fact, he spent a lot of time in prison. Brooke's first 7 is on the pay line. She has a history of childhood trauma that my Sunday school class don't want to know about. Her second 7 is on the pay line. Brooke simply followed her genetics, okay? Not making an excuse, it's just what happened. So Brooke is shooting IV heroin, IV fentanyl, and one other drug. What other drug is she shooting? Should be able to see that one pretty easy, right? All right, that's meth, right? Remember, meth is made out of stuff you get at Home Depot. So it gets deposited in your skin, itches, picks at it. This is where you wind up. She's 25 years old. She finds out she's 8 weeks pregnancy. Pregnancy's 40 weeks. She goes to her mom and says, I don't want to do this. I want help. So they Google doctors that would take women who were drug dependent and shooting and pregnant. My name popped up because my phone number's on the internet. They called me. I said, bring her to me. And Angie snapped this picture of Brooke 7 hours before I met her. Guys, right now, as of this morning, I'm responsible for the ongoing care of 3,200 patients with opioid use disorder. I don't see all of them, but I'm responsible for their care in one form or another. That's the toughest patient that I've ever had. Brooke Sargent was tough. I knew her for 2 weeks before she called me anything other than MFer. And she wasn't using the initials. And I remember specifically the morning I walked in the house. I said, hey, Brooke. She goes, hey, good morning, Dr. Loyd. I thought, oh, hell, what happened to the MFer? I mean, kind of liked it after a while. And so she had softened. What was she calling me MFer for? I hadn't done anything to her. I love her. Why would she call me that? She wanted to see if I was going to run. Everybody in her life had ran. Her baby daddy is in prison, right? Everybody in her life had ran. Her real dad ran. All right, she wanted to see if I was going to run. I don't run. And so Brooke and I became friends. And if I've got any therapists in the room that want to get on me about boundaries, talk to somebody else, I develop friendships with some of my patients. I'm sorry. I care about what happens to Brookie. So the good thing about pregnant women is you can absolutely scare the hell out of insurance companies with them. And I did. Every time I talked to them, I made her sound half dead. And I got to keep her a long time. So she's 38 weeks pregnant in this picture. Remember, 40 weeks, I got her at 8 weeks. So the difference between that first picture and this one is 8 weeks. She's in sober living. She's getting help with her underlying childhood trauma. She has bipolar disorder and PTSD, both of which she's getting help for. And all of it's covered by her insurance. It's not costing her any money, and she's doing well. The problem is Brooke wants to go back to Central Ohio. What's back in Central Ohio? Aforementioned baby daddy, okay? And that's the worst call I get from my girls. Hey, Dr. Loyd, my old man just got out. I hate that call. And I got it with Brooke. And a few days after this picture was taken, Brooke turned 26. What happens when you turn 26? You lose mom's insurance, and so she had to go on Ohio Medicaid. Guys, I'm an average doctor at best. I care. I care deeply about what I do. Average at best. But I take Medicaid, I take Medicare, and I take the uninsured. The doctor she goes to in Ohio takes cash only. And he's going to write her a medication, do nothing to treat her underlying mental health issues, do nothing to treat her underlying trauma, and charge her $125 every week just to write a prescription. No help with any of the other stuff. Oh, by the way, Brooke has 2 felonies. Possession with intent to resell, only Brooke is not a dope dealer. People's tolerances get so high on fentanyl that the amount that they have on them trips the scales on the weight, right? That's how they prosecute you. How it goes from misdemeanor to a felony, okay? The problem with that is she's a certified welder. She should make $50 an hour. Try getting a job with 2 felonies. I'll save you time. You're not going to. And they're definitely not going to pay you $50 an hour. She works at a convenience mart making minimum wage, okay? And she's paying a doctor almost everything she's making just to get her medication. Nothing else. So Brooke starts to struggle a little bit. So this is her and her mom, Angie, who sent me this from the delivery suite. I love it. Look at Brooke in that picture. 32 weeks. Guys, this is good stuff. Doesn't get much better than this, actually. This is what I do. And I get to see it every day. Brooke is a dime. Y'all know what a dime is, right? She's a 10. Okay? That's not Brooke. That is. She sent me this picture, first formal picture she had with her daughter, Ava. But she's struggling. She's struggling. Mental health issues coming out. Brooke relapses, gets put in jail. So you recognize that character right there? It's actually me with hair. You want to know why I have a hat on? It's because I'm bald. And I'm still self-conscious of it because I don't look near as good as Dr. Sanchez does, right? I just don't. He wears it very well, and I do not. So this is me. I'd always struggled drinking until I got in med school and didn't have a diagnosed alcohol use disorder, but I was not a successful drinker. The second day of medical school, my classmates elected me their class president. And it was the most impressive bunch of friends I'd ever had in my life. They're still my friends today, and I did not want to embarrass them. And so I didn't drink all the way through med school. I was a turtle on a fence post. I had my support group. I had them, okay? But then what happened on this day? Spread to the four corners. My support group was gone, and I was drinking within a month and using pills within a year. I love this picture. I'm a huge University of Tennessee football fan, big time. My son, Heath, right there, was born in 1994. The quarterback at the University of Tennessee in 1994 was a North Carolinian from Bryson City named Heath Schuler. So, of course, I named my son after him. That was the right thing to do. My daughter was born in 1997. Quarterback at the University of Tennessee in 97 is easy. It was Peyton Manning. And so I told Karen, we're having a girl. Peyton is a killer girl's name. I could have Heath and Peyton, back-to-back quarterbacks, right? And she said that would make us trash, and she wouldn't let me do it. So that's Haley. But this is my little family. We're standing on the back porch of one of my friends' houses on the lake, headed to Knoxville to a football game. I got my whole life in front of me. I worked hard. I'm the first person in my family to ever graduate college, let alone medical school. I make more money in a year than my mom and dad made 10 years combined. Everything is right in front of me. What's that in my pocket? It's not my car keys. I'd like to tell you it was. It's not my wallet. It's a bottle of pills. So I look at that picture. You can pick addiction out of Brooke's picture laying in the car, can't you? Easy. Can you pick it out of this one? You're going to miss this one. Damn near kill me. I love kids. Always have, always will, hopefully. We go to the beach. The parents sit under the umbrellas. I'm in the water with the kids. I still am. Only all those kids now are 30, and I'm in the water with their kids. Still do it. This is one of my favorite days of the year in some ways, and it's also one of my most heartbreaking years. Because we were at Disney World all day long, and I played all day. I got my son and daughter in that picture, my niece and nephew, and my two goddaughters. 4 of them are married, 2 of them have their own kids. And I look at that picture, and my heart breaks because I'm shiny. It's night. I'm dope sick. I ran out of pills that day. This picture was hanging above the mantel in my house in Johnson City. During the pandemic year, I came in. I said, Karen, can we please take that down? She said, why? I said, because I'm dope sick in that picture. I can't look at it anymore. You can pick it out when you see them laying in the front seat of a car. Can you pick it out of that? Guys, the foundational concepts. Hopefully you've seen this from what I've taught you already. Addiction is not a moral failure. It's a treatable disease. Addiction is treatable. Treatment works and people recover. It's my tagline. There are more people living in active recovery in the United States today than are living in active addiction. It's truth. You wouldn't know it, but it's the truth. And last but not least, addiction is complex and the solution is systemic. And what I want to leave here in Dare County is this. You have opioid abatement dollars flowing into this county. You need to be building a system of care that no matter where you touch this system, your patient gets the help that they need, not the help that that particular treatment system has to provide. So how do we go about that? First thing is we got to keep people alive. Harm reduction, pre-treatment. I like the term survival programs from the old Black Panther Party in the 1960s. We have to keep people alive. On every table here is overdose reversal drug, Narcan. Take it with you. Stick it in the glove compartment of your car. Okay? Take it to your kid's school, whatever. All right, you have to have unfettered access to overdose reversal drugs, and there's some better ones out there now for fentanyl. Op-V is the new one. It's longer acting. Hopefully it'll work a little better from fentanyl because fentanyl is longer acting than naloxone is, and you got to hit people multiple times with it if they're using fentanyl. Op-V, O-P-V-E-E. I hate to use trade names because I have this thing about pharmaceutical companies, but that's okay. We got to know what it is. So it's Op-V. So SSPs, y'all know what SSPs are? Syringe service programs, needle exchanges. And you'll have people all the time, oh, we don't want to do that. We don't want to do, we'll be encouraging use and we'll be putting ideas in people's heads, okay? And so I told this morning, I'm going to tell it again because it's appropriate. When I was 13 years old at Jonesboro Middle School in Washington County, Tennessee, a rural area, they talked about teaching sex education to us. And there was a big controversy. And the parents got together and said, you're going to put ideas in these kids' head. I was 13. I already had the idea. I already knew where daddy's magazines were. I'd already figured out some stuff. I did get some bad info from one of my first cousins, and I'm still a little salty about, but I already had the idea, right? We're not putting ideas in people's heads, guys. We've got to be realistic. And when you have syringe service programs that are available, you decrease the risk of Hep C and HIV in your communities. In Tennessee, we had thousands of our state prisoners who were locked up in DOC sue the state because we were not treating their Hep C. We were only treating 8 cases of Hep C. Guess what? They won. And now we're treating thousands of cases. It's a whole hell of a lot easier to prevent it than it is to treat it on the back end, guys. Just is. And we've got to have unfettered access to Verlac. Verlac is voluntary, reversible, long-acting contraception. You want to prevent babies from being born drug dependent, got to have Verlac. We got to have access to medications to treat opioid use disorder, and we got to have expanded services for babies born with neonatal opioid withdrawal syndrome. If you're going to touch this anywhere in the country, guys, you got to start in your county lockups, your jails and prisons. 75% of the people behind bars have a substance use disorder. Almost 80% of them were using a substance at the time they committed their crime, and 95% of them are going to walk the streets again. You got to take treatment behind bars. If you have somebody behind bars with opioid use disorder and they don't use when they're in there, when they get out, their first 2 to 4 weeks that they're out, their risk of overdose death is 40 times higher than age-matched individuals in the community. That actually came out of Chapel Hill. All right, we have to have warm handoff programs. It doesn't do any good to treat them in prison, and then when they get out, they don't have anywhere to go. Got to be a partnership, got to be a hot handoff. We got to have housing. Nobody in this room would look and smell like you all do right now if you slept on the street last night. Housing is basic needs, guys. This is Maslow. You can't take care of higher order needs until you take care of the lower order ones. The biggest one is housing. We got to have enriched prevention strategies. And I want to talk about this one for just a second. I didn't do it this morning, so I actually wanted you to hear this. And I skipped it this morning. I got time right now. You all have known me now for an hour and 30 minutes. What kind of student you think I was when I was in middle school or grade school? I was a discipline problem. Right? The first day of school, my new teacher already knew my name. Nobody else's name knew mine. Why? Because him or her talked to my teacher from last year who already did their time. They knew who I was the first day. I got put in the dumb classes. Kids know who's smart and dumb. I got put in the dumb classes. I was a discipline problem. When I got in trouble at school, they brought me around to the edge and where multiple classrooms could watch me get corporally punished with a paddle. What was happening in my house? I was being physically and sexually abused. You can paddle me all day long. I never cried. Hell with you. Never, not one time, never. Right? And when I got home and my parents found out about the spanking at school, then I cried then because that was a damn beating. That wasn't a paddle. Okay? You want to know who these kids are at risk? We already know. That's their first and second grade teachers. Okay? Everybody like me who comes from where I come from and get where I am, some point along the line you had a protector, right? All of us did, I did. And so when I was in the 7th grade, Tennessee took the standardized test for the first time. I think it was 1979, 78 or 79. And we got to color those little bubbles in. We all loved it. And after we took that test, a teacher came and got me out of this class and put me over here with these kids. And these kids were all smart. Hell, I thought I was smart. That one move right there changed my life. And the teacher that did it, by the time I figured it out as I got to be an adult, he'd already died. And I couldn't go back and thank him. All right, I had that happen for me. All right, I was being physically and sexually abused and nobody said anything. So we have an elementary school in Nashville called Fall Hamilton Elementary. It's a metro public school. If you go to YouTube and you search Fall Hamilton, F-A-L-L Hamilton, you need to. It's a little 8-minute video. So I learned about it after I left the state and I was like, oh my God, what are they doing down there? I loved it. They have a complete curriculum based around trauma. The zip code that those kids live in is the 2nd highest incarcerated zip code in the United States. All those kids are coming out of households where one or both parents are incarcerated or being raised by their grandparents or being raised by foster families. And they're in a metro Nashville public school, and everybody in that school, from the janitorial staff to the principal to the people who work in the office, are all trauma trained. It was unbelievable. I said, hell, I got to see it. So I jumped in my car and I drove down to Fall Hamilton Elementary School. I learned a few things that day. One is you can't just walk in an elementary school. Learned that one really quick. The guy with the gun was really nice. The principal was even better because he let me come in when he figured out who I was. And his name is Matthew Portell. He actually was a CNN hero for this. The whole curriculum was based on Stephen Covey's 8 habits of highly effective people. It's incredible. And I'm going to do it. I don't mean to. I watched these kids all day long that looked just like me. And they came in there, and when they got in trouble and when they were acting up, they didn't get corporally punished. They got redirected in other ways, right? People knew what was going on. And I cried the whole day, and I'm going to cry right now just watching it. I'm not mad about what happened in Jonesboro. I'm not. I'm just saying there's a better way to do this, guys. There's a better way to do it. And so when I was there, Matthew was teaching me all about it. I stayed the whole day, and they were getting ready to lose their trainer. She was the one that trained all the staff. The legislature was getting ready to pull their funding. You know how much funding they got? $65,000. That's all it cost, $65,000. And she trained everybody in the school. And so I went back to my company and I said, hey, if they pull that funding, we're going to fund this. They said, yep. Luckily, they didn't, but we were going to pay it. It's $65,000. Think of the difference in those kids' lives from that. When I talk about strategies that work, I'm talking about things like that. DARE didn't work. Didn't work. I'm not mad about it. But I see people right now spending their prevention dollars on DARE because they don't have anything else to do. There's all kinds of evidence-based prevention programs, guys, out there. And I'm actually a prevention guy. Okay? I use medication because it keeps people alive. I am a prevention guy. We got to have data collection. We got to look at outcomes. If you're looking at the treatment world, we don't look at outcomes. Have to look at outcomes, have to be willing to move our money from things that don't work to things that do work, and the treatment world doesn't want that. They want the money they got last year plus 4% if they spent their money from last year, and I don't want that. I want treatment programs that work. I want to measure outcomes. I want to see who's getting into recovery. I want to see what treatment fits the right person based on dose, route, administration, and whatever else AI can teach us. And we've got to have transparency and involvement of people with lived experience. Our Opioid Abatement Council in Tennessee has 15 members on it. How many of them you think have lived experience? One. You're looking at him. And guys, my lived experience is a joke. I woke up on third base and thought I hit a triple. Okay? I was born with a silver spoon up my butt. All right? I had every advantage known to man. I don't face what these kids that face out there. I don't get thrown in jail. When they intervened on me, they sent me to treatment. They didn't send me to prison. Okay? We need people with lived experience. So my life goes on. I got a registered letter in the mail not long ago, and nothing ever good, by the way, comes registered. This actually was. Our governor appointed me to the Tennessee Board of Medical Examiners. I just told you all my past. I should be in front of the Tennessee Board of Medical Examiners, not on it. But I'm actually the vice president. There I sit with my colleagues. I'm a turtle on a fence post. I didn't get there because I'm smarter than everybody else. I got there because I stepped into a system of care designed to put me here and there. And guys, that's the way I live my life. Not everybody's going to get a Hulu series. I've fallen ass backwards into more stuff than you can possibly believe, right? I don't know why. Not everybody's going to have that, but that's not what everybody wants, right? What happened to my friend Brooke? So Brooke gets arrested. She gets put in jail. She's on Subutex, 8 milligrams of Subutex a day. That's all she's on. Somebody without a medical license or a degree decides they don't like that medication and she doesn't need to be on it, so they stopped it. Because they don't have a medical license, they don't have any training, they have probably a high school education, and they stop it. And she stays in jail for 30 days. They don't give her any of her mental health meds that we actually got her back on, believe it or not. And when she got out, they didn't refer her to anybody for treatment. And on the morning of December 13th, 2020, my phone rang really early in the morning, and it was Angie. And I answered the phone, and she said, Steve, I found Brooke in her bed this morning, cold and blue. Brooke died of an acute overdose of heroin and fentanyl. She's one of the 107,622. That's why I still use that slide, because Brooke's one of them. Guys, these aren't numbers. These are people's moms and dads, right? You say, okay, well, that one's over. We're done. We can be finished now. We'll kill our way out of this. There's a problem with killing our way out of it. That's the problem with killing our way out of it. Let's look at Miss Ava's slot machine here for a second. What's her first 7? Mom, dad, both with drug addiction. First 7 on the pay line. Ava's ACEs score is 2. She's only 2. Okay, in that picture, she's holding it now. She's only 2. Mom died, drug overdose. Dad in prison. That's an ACEs score of 2. She's only got to get to 4. If we don't intervene on this child, what are the chances this child's in our system in 15 years? It's damn near 100%. We've got to change our strategy. Guys, we've got to change our strategy, and there's a way to do it. My second favorite slide is this one. It used to be my favorite slide. This is my family. I took them to Florence, Italy a couple of years ago. And a little boy growing up in Jonesboro, Tennessee, never dreamed of going to Florence, Italy. That's the Duomo in the background. I didn't even know what the Duomo was until we went there. That's my son, Heath, my daughter-in-law, Laura, my wife, Karen. That's me. I want to focus right there for just a second. That's my daughter, Haley. And Haley is where all my money goes. And so I'm a firm believer in the old double standard. When Heath grew up and it was time for him to go to college, he needed to get the hell out. I love him. It was time for him to go. I mean, it really was. It was either him or me. All right. Haley, completely different set of rules I had for Haley. I told Haley, I said, Haley, if you'll live in your room, I'll pay for everything for the rest of your life. Cars, anything you want. I'll actually give you my room. I'll move into yours. And that didn't work. And when she was a junior in high school, she brought this thing here home. His name's Sterling. They were going to the junior-senior prom. He was a year older than her. He came up in my driveway. I looked at him. I was like, oh, God, Haley's in the house. I talked to him for about 5 minutes. Walked into the kitchen, told my wife, Karen, I said, Karen, I think I met our son-in-law. She's like, what? She said, it's our first date, Steve. I said, well, I'm telling you. 6 years later, I'm standing at the end of a long aisle in Charleston, South Carolina. I told the group this morning it cost a fortune. So the dads in the room, don't save for college. Save for this. Way more expensive. And Haley's on my right arm. I'm getting ready to walk her down the aisle. And I'm a mess. I'm crying. It was ugly crying, too. And right before we walked down, she put her head on my shoulder, and she said, Daddy, you're the first man I ever loved. Thank you for everything you ever did for me. That's a great moment, right? But for me, it's even greater, and Haley has no idea about the backstory. I knew that night I was not in parentheses in the program we handed our guests. I'm a dash. May 11th, 1967, dash. That's me, right? And I'm a dash because I'm a turtle on a fence post. Somebody stepped into my life 20 years ago and put me there, okay? Now, for the dads in the room who are looking forward to this moment, it's a damn good one. It's a damn good one. At the end of the night, when they get in a car and they go to a hotel, that sucks. They've been married 7 or 8 years now, and they come to stay with us, and every time I want them to sleep in a different bed. They don't. They haven't yet. They haven't given me any grandchildren, so I'm getting about that. So Heath is getting married in the pandemic year. He's getting married in October. And he played college baseball. He's got 100 buddies. And they're all living with me in April. He's getting married in October. They hadn't bought their houses yet. So they're all living with Karen and I. He comes down to the dinner table and he said, hey, Pops. He said, would you be the best man at my wedding? Guys, the 2 biggest days of my life I would have missed. Nobody else walking my daughter down. Somebody else walking my daughter down the aisle. Somebody else standing next to my son. It was me. I'm a turtle on a fence post. We've got to take these opioid dollars and we've got to build a system of care that gives people a chance at this. This is the goal. It's what we want to do. Okay? This is it. Now, I told you it was my second favorite slide because I think if Debbie's right, I now have my first favorite slide. So September 15th of this past year, this is my granddaughter, Cece. And she's changed the ball game, right? I get to be a granddad. If we do a good job with this, Cece's only 1 generation removed from me. My kids have never seen me take a pill. They've never seen me drink a beer. They were little when I got into recovery. Cece will know none of that. 1 generation away completely changed the Loyd family tree because our family was riddled with addiction and drug overdoses. And just by helping me, she'll never know. And guys, that's the reason to do what I'm talking about doing. And we got to get serious about it. We got to love people unconditionally. We got to forgive habitually. We got to demonstrate mercy. And for God's sake, we got to stop kicking them out because we kick them out to die. Thank you all.
We definitely have time for some Q&A, so I'm just going to go around the room. If you have questions, raise your hand and hand you the microphone. Okay, well, the first question, we want to know about beverage control.
Love the withdrawal. So beer withdrawals, the chemical pill form, which is dirt cheap. You probably hear it again, that's the boogie voice. But we use injectable naltrexone. I love it because get somebody in the rear end, it's 30 days, and for the patients it works for, it's wonderful. It really is. Limitations of it, one, it does not have a mortality benefit. Okay, it's the only one of the three that does it. There's some reasons for that the company doesn't feel like talking about it a whole lot. But it doesn't have a mortality benefit. And the second issue I find with it is when you get somebody who's injected, and they're injecting more than a gram a half a day, you got no shot. You really got no shot. The best place that I found for it is in criminal justice. Why? Because we've got accountability and we can hold people in the process. So I absolutely love naltrexone. So here's the issue with naltrexone. It is a complete opioid blocker. So if you've got these opioid receptors in your brain and you're taking it exogenously, okay? And when you start taking it exogenously, your body responds by making more opioid receptors, right? And so now you're going to need more and more for less and less effect. Because remember, it's not the opioid receptor that gets stimulated that leads to the feeling you want. It's actually dopamine attaching to the dopamine receptor, right? That's what you're looking for. And it's a chain reaction, of course. But the whole time the opioid receptors are going up, the dopamine receptors are going down. So you need more and more for less and less effect. Okay? Now, we block all the opioid receptors with naltrexone. Your body will start to internalize those opioid receptors that they've upregulated over the patient's use. And you stop taking the naltrexone and you relapse. And you go back to the same dose that you were using before you died. And the company does not do a good job with warning people about that. I teach all my patients about relapse. All of them. And I love naltrexone for the patient that works in. It works great, and we use it. Limited areas, you've got somebody sticking the needle in their arm, very difficult to get control. Not telling you impossible, I'm telling you difficult.
Other questions?
Yes, ma'am.
For OB providers, for patients that are pregnant, but maybe they don't need to dose of methadone, what's your decision to choose Subutex versus Suboxone? We don't prescribe it currently, but we have patients that are on it. So
Yeah. First of all, I encourage you to start prescribing it because it's a great feeling you watch your patients get better. There's no difference in the two. So we say in Tennessee that the only patients we'll prescribe Subutex for are patients that are pregnant. And the reason for that is really pretty sketchy. So there were two cases back in the day where a patient, mom had received naloxone and the baby had a seizure when it was born. Okay, you got to remember these people who use drugs, so there's a lot of confounders there. So they said only Subutex should be used for pregnant patients based on that, which is very shaky at the least, at best. But what we found is if you look at the mother study, which was done in 2010 compared to methadone and buprenorphine, they used Suboxone in those studies for pregnant women. There was no difference. So realistically, no difference. And I love using buprenorphine much better in pregnant women than I do methadone. Methadone, they got to go to a clinic every day. What I consider to be really good methadone clinics are kind of few and far between. All right? A lot of them are home with private equity and hedge funds and things like that. I'm not saying the for-profit clinics can be good. They can be. You can have some non-profit ones that are bad. But in general, I think it's a little more difficult whenever you start getting into the, hedge fund and that kind of things. And, just have to go to the clinic every day. Right? So I love buprenorphine if we can get control. I would have told you 10 years ago that methadone would not exist in 2024. I didn't think we needed it because buprenorphine was so good. I just didn't see fit. I get people now tell me, oh, I saw fentanyl. These are the same people that saw the stock market crash 2 weeks after that. Because you did. I heard nobody talk about fentanyl in 2012. Nobody. All of us talked about heroin. We knew it. Right? We're going to cut the pill supply off. We don't have treatment for these patients here. They're going to use something else. What's cheap and an opioid? Heroin. So we all saw heroin. Nobody saw fentanyl. And fentanyl is really, if I look at the patients that we treat now, we probably have more patients on methadone than we do buprenorphine, which for me is really scary. But there's some good stuff coming. AI has changed the ballgame on drug development, and I barely operate my phone. It's over at 12 because I can't remember the stars today. But I do know how to use it when people teach it to me. And AI is changing the drug development world right now. And so there's a couple of drugs in the pipeline that are non-opioids that actually change the pathways in the brain that I'm extremely excited about. I can't wait till we have something better to use. Right now, it's the best thing. Yes, ma'am.
Do you find that when people leave treatment centers, they have trouble getting Fentanyl?
Oh, yeah.
Because I've had that experience.
Oh, yeah, you'll have all kinds of trouble with that. And that's really a shame. You shouldn't have trouble getting it. And, like I said, it works really well in the criminal justice system as well. But there are providers out there. You can ask the sales reps and they'll tell you who they are. But we use Fentanyl all the time. But, I was trying to think, we talked about this with our meeting talking about it, I can't remember the last time I got a patient using pills. I can't even remember. Everybody I have is using heroin. I cannot remember the last time I got somebody that came in and was using pills. And I think whenever you start getting people using heroin, fentanyl, and they're injecting, it becomes markedly more difficult to control than naltrexone. But we're still trying. Yes, sir.
So we got a lot of those different programs on that slide that you showed, right? And you spent any time talking about the importance of leadership and bringing people together so that we don't just throw stuff in.
Oh, man, I need to take you with me. Tease. You're exactly right. Policy is huge, right? I mean, you've got policy things that are blocking, but here's what I want to do. And it's actually why I was in Las Vegas, because I wasn't at a medical conference in Las Vegas. I was actually at an analytical conference. And my kids were cracking up that I was speaking at a conference on analytics. I'm really interested in the predictive model. We got all these strategies and all these buckets. How do we know where to put our dollars in each of those strategies to get where we're looking at? So I want you to think about this. Our goal here is to shrink the number of people using drugs, right? That's our goal. So if we imagine that as a bathtub, there's 4 people who are using drugs. You got a faucet coming in, you got a drain going out. That's your system, okay? So if you take all your money and you sling it in Narcan, not a bathtub, right? So when you come out of the system, you come out of the drain, there's only 3 possibilities. 1, you get into recovery. 2, you flip back and forth. 3, you die. Those are your 3 possibilities. So we're going to take all our money and we're going to sling it in Narcan, right? What does that do to our number of people who use drugs? It grows it. Because you're going to stop them from dying, and I'm not up here advocating to let people die. I'm telling you, you're going to stop people from dying, so they're going to go into one of those other 2 categories. So you're going to get recovery, or you're going to flip back and forth, and you've done nothing to address the input. You're actually going to grow it. So there is something out there called systems dynamics. I have no financial interest in it. I don't know any stock, okay? But I learned about it in the opioid cases we were doing, because I told you I was a leadoff here. My job is to draw a line from here to here. It's called causation. The guy right after me did systems dynamics. And he modeled the system using predictive analytics and showed, if not for this, this. It's basically the question he asked. And when we saw that, we said, can we not take that same thing and apply it to the opioid knowledge? And the answer is yes. So you can actually look and see, using your investment strategies and how much money you have in your current system, and you can predict and model and look and see what your outcome should be if you put your money in these piles. And I love that. And I want to measure it on the back end. Okay? Now, the problem is, how do we get people out there to understand it? Okay, so we are in the county we're in right now. Is there a county mayor or a city mayor or both? Yeah. Was that multiples? So you've got a couple of mayors, and then normally you've got a city council or a county commissioners, right? Something like that. 85% of the opioid dollars in the state of North Carolina are going directly to the counties. So we got to get to these folks and help them figure out how to spend it. Because if we don't, they're not going to spend it the way they need to. They're not nefarious people, right? But out of intensity, I've run into everything because I'm the chair of our council, and I had a sheriff in a county that I will not name. We have 95 counties in Tennessee, and so I had a sheriff call me up, and he wanted to take his abatement dollars and he wanted to spend it on stun guns, and he wanted to sell it to me as harm reduction because hell, at least they weren't shooting. Good college try, right? And so what I did is I went down and met with him. He's not a bad dude. Not a bad dude at all. And I showed him how to use those dollars in his jail. You can actually build an addition to the jail if you need using these dollars. The only thing you got to do is put a treatment program in there, right? And that'll work. And so those are the things that we have to do. But I'm a big fan of predictive modeling and analytics on the back end and using those things to make policy decisions. Because if you think about predictive modeling and analytics, you can look and see what the results are when you pull certain levers. And the big lever is policy. What happens when your state legislature does this? And we can show you what the outcomes will be. Now, going down and showing them, having them taking action on those 2 different things. But I agree with you 1,000%. And it's actually why I was in Las Vegas. The only reason I went out there. I'd much rather be here. Yes, ma'am. Oh, look, I wanted somebody to ask this question this morning. So, talk about the weight loss drugs, specifically Wegovy. Those drugs quell cravings, and they quell them in the reward system of your brain. I told you all the pathways we're talking about are the same. Food, water, sex, right? And so there's actually some really good data that these drugs quell cravings. and are going to have the benefit in substance use disorder. And I'm really excited about that because they don't bring the baggage of being an opioid along with it. So that one fires me up big time. And so, you know, almost, I guess, very little of it's being used to treat diabetics, and most of it's being used to treat, obesity or being overweight. But I think that those drugs definitely bear more study just simply because we know the mechanism of action. And this is one thing people don't realize. One of the highest groups at risk out there of developing any type of addiction is actually people who've had gastric bypass surgery. Right? And if y'all ever, anybody ever seen somebody for gastric bypass? I used to all the time, right? So they make them go to one therapy visit. Boy, you talk about window dressing.
It used to do more.
Yeah. The last time I saw somebody who was born, I was like, you gotta be kidding.
6 months.
Yep. And because it is a food addiction, right? And so you're gonna send somebody to one therapy visit. So what happens is you send somebody for gastric bypass and you take away their drug of choice, right? Food. They don't get the pleasure they do. So they simply switch over to alcohol or painkillers or whatever. The rates of substance use disorder in people who have had gastric bypass are through the roof. Absolutely through the roof. So if you've got patients like that in your clinic, and I'm telling you, you need to be addressing this. And you need to warn them and let them know. And I had a young lady who was like that. She really wasn't very overweight. She could have she could have done it a lot of other ways, but she chose to have gastric bypass. And I begged her not to because I knew her family. And her family was riddled with addiction. And she did it anyway. And of course went down that road, got on pain pills, started shooting heroin, and they put her on the front page of the newspaper because she got caught smuggling heroin into the jail in her vagina. Okay, and so they put it on there, and there's a big story in the newspaper. The problem with that is her son's on my blue list. Right, that's the problem with it. I get what you want to do there. You want to shame the hell out of it. I got that. I still don't agree with it. But you forgot about the boy. Right, and all his buddies see it in the newspapers. And so these are the kind of things we got to think a little harder about before we do it. But that one's the one that always hits on me. I appreciate you bringing it up because I wanted somebody to bring it up this morning. I'm really interested in that. And you're all allowed to kick me out of here on this one. Maybe it's a good thing to end on. I'm also interested in psychedelics. I am blown away with some of the data that I've seen on smoking cessation and one-time use of psilocybin. It's really incredible. And when you start talking about psychedelics, we're not talking about going down a trail, dropping acid, and listening to the doors. All right, we're talking about a guided psychedelic experience with a trained professional, like a trained psychologist or psychiatrist. And it's a one-time thing. And some of the smoking cessation rates have approached 40% over the long term, and I think that's just, I mean, we are since
But also using it for trauma, they're testing it in the U.S.
Absolutely.
military right now. So if you can solve trauma, then you can solve addiction.
Absolutely. You start looking at drugs like MDMA, right? And so I think it's really interesting. If you're interested in this topic at all, there's a great book written by a guy named Michael Pollan. It's called How to Change Your Mind. And it explains this. And Michael is a really, really good writer. So you're not reading some, techno, PhD somewhere who's reading something nobody can read. This is actually a readable book. It's a New York Times bestseller. But it is absolutely fascinating. So I'm very interested in psychedelics. I am not interested in putting it out there for the public to vote on whether or not we should use it. I'm interested in going through the pathways that we have to establish the effectiveness of medications. Yes, I think oh, man, I'm sorry, I got my glasses on.
You had started out saying that you were lucky because you were under the physician's board, right? So you got monitored for 5 years, and the rest of the population doesn't, right? So the lawyers and pilots get that, and we know the success rate is not 8.5%. But for the rest of the population, what is your opinion on what we do to kind of mimic that model?
One place you can mimic it in society, criminal justice. So if you look at, because I didn't talk about large, I didn't talk about airline large, you're exactly right, so thanks for completing that. So those have similar programs as doctors do. There's only one place that you can mimic what happens in those programs, and it's criminal justice. So if we look at programs for physicians, lawyers, right, they have 3 big components. 1 is a high-quality evaluation, 2 is long-term treatment, and 3 is effective aftercare and follow-up. And I would even throw a 4th one in there that I affectionately call the big-ass stick. And the big-ass stick is this license, right? Where else in society does that exist? Criminal justice. And so if you look at drug courts, well-run drug courts have success rates approaching what we see with doctors and airline pilots because it has those necessary components. I'm not saying that you should have to go. I get the harm reductions beat me up for this all the time, and I'm sorry, but if they're already in trouble, let's use that trouble to help them. Because there's only one predictor of positive long-term outcomes. What is it? Time in treatment, time in the process. Not drug screens, not therapy, not even trauma that I love so much. It's time in process. How can we ensure that happens? Judge. And so I think that's the place for it. I think it's our best opportunity.
How do you help those who have the dollars and manage the funding understand the importance of trauma?
It's damn hard. That's what I do. Right?
Because that's prevention.
It is.
We get these kids in elementary school and we heal them from trauma that they might not start using drugs.
It's so interesting because now, I was telling my table at dinner, I still see patients. I mean, I do this, but I saw patients today. I mean, so pretty effectively on my computers, I come up the road breaking a bunch of laws. But I still do that. I do. I'm sorry. But I told our board not long ago, I'm 57. I think I got 15 years of working life if I stay healthy. And I asked them, could I spend the next 15 years in jails and prisons? And so that's what I'm going to do. I've already started it. And I think that, it's hard to get people to see what we're talking about, right? They don't understand the importance of trauma. They don't understand the importance of addressing trauma. But I think that the more success we can have, and I think we really have to target the criminal justice population. It's by far the biggest one out there. And you're not going to move the needle if you don't address it. And you're not going to move the needle on helping people in long-term treatment without treating the trauma. And it's hard to get people to see it. It really is, because what they want is they want one thing, one lever to pull. And is there anybody in here? I know you're an elected official, so I want you to just not listen to this. Okay? Here's the problem with elected officials on this, that they're looking at this. They want to see it solved in a 2 or 4 year election cycle. Okay, we'll know we're successful with prevention a generation. Right? I'm so interested about fall habits in elementary school. That day moved me unlike most of my days. I mean, I was moved to tears that day, and I saw the possibilities there. Does it pan out? How do you take somebody out of a trauma environment and help them build the resilience of factors that lead to long-term success? Can you just do it during those 4 years of elementary school, or does it need to be longitudinal all the way through? My guess is longitudinal.
Well, part of that is because of brain development.
Absolutely, yeah, we talk about it all the time, right? So, and this is the other interesting thing. But fentanyl's changed the ballgame on this. But before fentanyl, how did most people get out of addiction before fentanyl? Anybody know? They grew out of it. It just kind of burned out over time. I think it has to do with brain development. It's kind of burned out over time. The problem is fentanyl, there's no time, right? And so I think it's really interesting. It's a great point. What do you do, Bubba? Okay, I felt a little flirty. I was ready to sit down. I want to tell you how bad a bitch my mom was. Quick.
That was an interesting piece. I caught on something really fast. Sitting back here, I'm a physician assistant. Okay, what do we do? I got somebody who's they're looking for help. Where do I send them? We have a couple resources. And you said something, well, you know, therapy's not going to do it. We got to get into the program. I heard that. I thought therapy was the program. What do I do with that?
People are going, what you do is what else. That's I told the group this morning, if in 2004 you just put me on medicine, and you don't know what I think about medicine, I love it. What if you just put me on medicine in 2004 and that's it? I mean, there's a chance I would still be in recovery today. Would I be where I am today? Not like that. I've changed everything. I am not the same guy. It's markedly different. Guys, it was hard damn work. But what you're getting into is when is it appropriate to start there? So let's go back to the brain. Right? I see people come in and they want to stick them in and start talking about childhood trauma on day 2. Day 2, they don't know that the sun comes up in the morning. Right? So we talk at Cedar, and I'm not here to plug our program, but it's just principles that we try to live by. We talk about feeling better, getting better, staying better. First thing they do, that patient you're talking about, what I do right off the bat, I got to get them feeling better. If they're no hungry, they're going to use. I have to get them feeling better now. I've got somebody addicted to opioids, so this is what I put together in Davis County, which is Nashville. Nashville's about 1 million happy. Okay? We've got a great sheriff. I have a huge man crush on him. He is awesome. Okay? But Darren Hall, and And so he took dollars that came into the sheriff's department there and built a mental health center within the jail. And so now if you have a mental health issue or a substance use disorder issue, and you come in and you haven't committed a violent crime, instead of turning right and going into cuffs and stripes, you turn left and go into normal clothes and get help with those things. It's phenomenal in downtown Nashville. And the first thing we have to do is we have to get them feel better. Okay, if we don't, they're going to run. And so how do we get them to feel better? Medication. Get them to feel better today. May or may not need to be on it long term. Get them feeling better right now. If we don't, they're going to run. Now, I wanted to show that slide so bad because I have such a better slide than North Oak did in 1993. If you look at frontal lobe development, you start to see that frontal lobe come online in about 3 months. It's been my experience that that's not in bad time, that 3 to 6 months range to start dipping your toe in the water.
So, are you going to get that back on buprenorphine or?
Slower, but yeah, slower. Yeah, just be slower. When you finish, I'm sorry.
Yeah, I still got stuck on the program. It's not therapy. Like, okay, it's not that it's not therapy. It's bad.
So
Here you go one place for the drugs, go somewhere else for the
you're
therapy.
getting terrible.
So yeah, we don't have that's we're all sitting back there going, I like your idea. Who's going to do it?
Yeah. So it's what I'm trying to do. That's why I put this slide. This is the system that we have to build. It does not exist. And so, first of all, you've got to feel better. Right? We got to stop them from being sick. Next, you got to get better. How do you get better? What you do. And then long term, how do you stay better? How do we go from that? If you can get somebody to 5 years in recovery, what are their chances of getting 15? Anybody know? Damn near 90%.
Listen to what you described as I don't know about it, yes. My patient population who's doing this isn't in jail yet. So they're almost better off if they go ahead and hit that rock bottom. They're going to get better help. All the patients that I'm seeing in this regard are middle class. Their state laws is barely getting by, but they're almost better off if they end up in jail because they're going to get better care.
Yeah, the first drug court I was on, I got in trouble with the judge because I love him and he's a great dude. And we didn't have a drug court in Washington County. He was in Greene County and I was working in Greene County. So I had patients like we were talking about, so I told him to go get caught shoplifting in Greene County. He didn't like that. We shouldn't have a treatment system where we got to get somebody to go to jail. Right? And so that's what I'm talking about. The system I put up here that I put on the board is called recovery-oriented system of care. That's what has to exist. And we got to build it. And it's what I'm trying to get people to see. And I get frustrated because it doesn't happen fast enough.
But the jails are tricky now.
They are.
So we don't have anybody there as long as.
You don't need to. You have a judge. And the judge sets a condition of their probation. Okay? And the judge can set their condition of probation to be compliant with your treatment program and bring you back in with frequent appearances. Sure.
Like I go in there,
Yeah.
I work with someone else and we work on it.
Yeah.
Based on, especially with and sometimes they want to go for themselves because they don't want to finish their sentence.
Yeah.
They would rather go to treatment, and that's great.
Of course.
But those are faith-based treatments for the most part that are free, and they do not even allow them to take mental health medication.
All right, so we got to get rid of that stuff. All right. I can do this.
That's also part of the systemic breakdown of this issue, is that we don't have non-faith-based programs. We have a holistic approach rather than Jesus based.
Yeah, but-
Except for TROSA and recovery measures in the state of North Carolina that are available without cost.
I never realized Jesus was spelled G-E-E-C-U-S, but it is. And I've been able to hit over the head with Jesus so many times I get sick of it. And I am a Christian and I go to church and I also believe that God put doctors and therapists and people in the world to help that. If we have cancer, we don't send somebody to pray for you. We do, but we also send you to an oncologist. And so when you have somebody like that, they're treating addiction strictly as a moral failure. I love faith-based programs. When they work, they're great. Okay, but don't tell me it's the only way. I got guys that go out in the woods with their Bible, blue jeans, and white t-shirts and stay for 6 months. If that works for you, hot damn, I'm all about it. Don't tell me that's the only way it works. I will not listen to that. And the programs that you're talking about, if they're denying medication, they're getting federal funding, they're in violation of the law. Yeah.
Do you have a Portugal model?
What's that?
The Portugal model.
Oh, of course, yes. Absolutely. Yeah, it's, if you're receiving federal funding in your drug recovery court, really anywhere, and you are not allowing patients on medication, first of all, you have no medical training to practice medicine without a license. That's another story. But you are actually in violation of federal law. You have sober living facilities. I had a sober living facility come to me and says, here's what patients need to do before they get in here. And I said, hell, if they did all that, they wouldn't need you. All right, and so I'm almost a housing first guy. I'm really close.
So they can't get nonprofits. What is it? They're writing.
If they get federal funding, either through the block grant that comes from the feds to your state and doled out, however it comes through the feds, they're getting federal funding. They cannot deny patients medication. It's a violation of the Americans with Disabilities Act. Jails right now that don't treat people with medication are in violation of the ADA. They're also in violation of the 8th Amendment of the Constitution of the United States. Yes, sir.
Yeah, coupled with that, so few understand it and they the approach despite overwhelming evidence. And I know you had to fight that battle when you entered in the private treatment world journey. Do you see virtual treatment for those of us that do provide that level of treatment? Do you see virtual treatment providing any sort of relief?
Yes, I hope so. I mean, I think there's a big need for it. I mean, the pandemic sped up everything so much, right? I mean, literally we got rid of decades worth of minutia regulations. It really went away overnight, and the world didn't fall apart, right? And so I think we've got to be looking at ways to develop virtual treatment. You're never going to get a sexual trauma expert to go to Cobb County, Tennessee. Ain't going to happen.
That's all we have here is virtual treatment. Yeah. I mean, if our patients are seeing a psychiatrist, they're driving an hour and a half, 2 hours, all we have. So we've got to the point where when we think somebody's medication management is beyond our scope. Therapy, okay, but medication management is beyond our scope. We're giving them free websites. Whoever gets you first wins. Yeah. Because,
And then it's luck of the draw. So that's what I'm talking about here. I want us to build a system that no matter where you touch it, you get the help that's right for you. Because here's what happens right now. You get the help that the place you get sent to provides. That's a big difference, right? If you're a hammer, everything's a nail. And it's unconscionable to me. We wouldn't do that with any other disease that I know of. So, as I'm talking about building this from the ground up, because what people want to do is they want to take all these little pieces we have out here and somehow fashion it like, God fashioned Eve out of a rib. Okay, it's not going to happen. You have to look at what I'm talking about here, and it has to be that driven. I think it is doable. We're already spending money. I mean, even without the open debate money, we're already spending. Where are we spending the DOC? We're spending Department of Corrections. In most states, it's the second biggest line out in the budget outside of education. Guys, I appreciate y'all. Y'all been great.